Can you?
Now go ahead and
But can you hear me?
barely.
Well, others can hear it.
Yeah, now I'm just not seeing it up here.
Okay.
Okay, I think we're all right. Thank you.
You're welcome.
I think the system maybe just needed to warm up.
It's tired. Yeah, we have more guests than we have members here.
My girls will literally in the summertime they go outside to play, and they come in and their faces would be sweating with hair running down their faces, and then they'd come and I'd call them in for lunch, and they'd say, Mom, can we pack a lunch? They want to get back outside and play with
That's what we did growing up. People are afraid to do that now.
They don't even know how to get out and play. I mean, really, it is sad. I mean, the only thing they say is, I'm bored.
Well, that's my theory. When you see all these kids wanting these safe spaces and stuff, they've never been out there to fall off of a bike and to realize they can pick themselves up or whatever else,
I climbed the roof one time and got in big trouble.
Oh, yeah.
It's really
Yeah.
sad that kids don't get it. And then if the neighborhood kids would pick up, one of my girls came home and said, Johnny, you pick up. Well, either don't go to Johnny or go figure it out. That's it.
Yeah, it's like,
Johnny's mom, and she's causing ruckus. But out there, and then the parents said, but out there, that little my daughter's a high school teacher, and she said, Mom, you give a kid a consequence for not turning in their homework or whatever because the parent comes to school and, she had this one kid that wasn't turning in homework for like 2 months, and so when his grades came up, Mom came in all upset and said to my daughter, well, you lost his papers. He told me he was going to turn in his homework. She didn't lose his papers. So she was a little bit smarter than Mom. She says, well, let's do this. Let's have him turn his homework in by email, and we can include you on it. And sure enough, but here's the problem. She's automatically going to say, as a teacher, lost the papers.
I would hate to have that job today because
there's no discipline. They sit there and
well, they don't do anything because they can't. I mean, it's almost as if you just let them be wild, and what good does that do? When they're young, it's the time to learn consequences of growing up instead of when they're older. Yeah.
Hi, ladies.
He's going to join us. Hallelujah.
well, then you grow up to be an adult who wants to work and
Yeah. Yeah. And that doesn't do any good.
no, it doesn't. And that's there is no discipline. There is no manners. There is Now listen, I worked for Walmart. All it is cameras. And the shows are all working. And they're hearing, oh, this is too hard. I think it's so Maybe all kids out of when I was a teenager living in eastern Nebraska, you worked the cornfields or the bean fields in the summer. That's what you did during the week. You tassel corn all summer. Really? You guys don't know.
Yeah.
Jumping out of the barn. I never did that.
Have you been?
I'm doing well, thank
Well,
you.
good.
Life is good. You?
It's doing well.
The weather just... I'm in the mountains every weekend.
I know, it's been incredible, hasn't it?
Yeah, it's crazy. I got an
It's
ATV.
so dry, though.
Pardon?
It's dry, though.
Oh, yeah, really, the dustiness. I bought an ATV, so I did Creed and rode over Stony Pass to Silverton. And I did Fairplain, rode over Mosquito Pass to Leadville. And I went down to Alamosa.
It
and
is
did
so
a lot.
beautiful.
Great, yeah, it's been a good fall.
Yeah.
How long can it last? We've ridden motorcycles down there south. On the 20th of September and got snowed out.
Well, we went down, yeah, I guess it was the week before Labor Day, to Telluride. And all the colors were at the peak. And it was just gorgeous. Monarch, all of the colors, everything was great.
Yeah.
But it had snowed on mountains, so we had rented a Jeep to go up. We wanted to go up in Imogene and all of those areas.
Yep, I've done all that.
And we couldn't, yeah, I've done it too. But we couldn't go past Tomboy above Telluride because of the snow. And then, but we did make it over Ophir Pass, which,
Done Ophir.
oh God, that one just scares me.
Yeah, it's pretty steep over there on the side. Did you ever do Black? That's the scariest one there
John
is.
has. He
The
has.
scariest one.
I have never done it.
We did it on motorcycles a
I
lot.
thought I'd walk it, but I don't think I'd do it.
Almost every car we ever saw doing it, everybody would get out but the driver because it's, you know what it's like?
Yeah,
It's like this
yeah.
and like this, and then there's a
16
creek down
point
here.
turns.
And then it does this.
I know.
The car jumps to the side.
Not for me.
One of my favorite memories. Legal services first.
How are you?
Good morning.
Good. I missed a couple minutes. I feel like I'm out of touch.
Order, please. I'm delighted to see all of us on the rack, as well as our grand audience. I think our grand audience is half made up of presenters. And I'd like to say thank you for doing both roles. Because without you, our function doesn't really happen. I would like to, we have a quorum, I see. Thank you all for coming to provide this quorum for us, because we can do this. Appreciate it. If you look at the agenda and see if there's any items that you'd like to add or discuss, if not, you can motion to discuss.
I'll move to approve the agenda.
I'll second it. If we do the second, all those in favor?
Aye.
Opposed? Not yet. Public, I need to ask for us to go around the room and introduce ourselves. First of all, I guess, Carrie, since you're doing dual role, you better.
I'll just introduce myself once. Carrie Schillinger, Area Agency on Aging.
Phyllis Huggins, Eastern El Paso County. Cheryl Schnell, Department of Human Services.
Gary Novak, Colorado Springs.
Betsy Anderson, Teller County.
Dixie Herring, the Independence Center.
IUC on Fountain, Colorado.
Francine Trevine, El Paso County.
Alan Massey, Colorado Springs.
And Angela with Colorado Springs. Bobby, now that you have your Wait, should we start at the other end of the row and then you'll be fine?
Sarah Lipka from Colorado Legal Services. Bobby Moore with Part-Time Senior Fellowship. Marianne Harrison with the Vista Community Health Center. Kristen Harper, Peak Vista Community Health Center in Colorado. Chris Breyer, Peak Vista Community Health Center. Clark Cottle, Alzheimer's Association. Lisa Aldridge, High School Area Council, Early Area ACLU. Laura Engelman, Socializing. Ned Ellis, Silver King.
Todd Coffey with State Union on Aging.
Brianna Knetsky, State Union on Aging, Colorado Department of Human Services. volunteer, Area Agency on Aging, Cynthia Oski. Jessica McMullen, I'm the new Policy and Communications Manager for PPACG.
All right, thank you. I appreciate you all being here. I'd like for Gretchen, would you come up for a minute and just say good morning to this is, I think, the first time you have met at the part of the community, is that true?
This is my first time.
Terrific.
My name is, again, it's Gretchen Bricker, and I am new to the position for the team lead of the direct services for the Area Agency on Aging. This is my first week, so I won't remember anybody's name, sorry. But Lisa had asked me, Carrie had asked me to just give a little information about my history, and I'd say it probably is the most, the overview is most of my experience has been with medical case management. So I've worked in long-term care facilities. That was kind of where I started. And I've been at Memorial at the Senior Health Center in their case management. That probably dates me a little bit. Also been in Memorial for their inpatient rehab, Health South inpatient rehab, private case management. And most recently, I worked as a social worker for the Rocky Mountain PACE program. And that was for the last 7 years I've done that. So I'm really excited to be here. And it's a great, I know it's a great group. And I just am learning an awful lot. So,
Appreciate it. Thank you. And we'll be seeing you more, and delighted that you would come and say a few words. Thank you. All right. Are there any public comments? The items that are not on the agenda, I see public comment coming.
Must be Lisa.
No, I have a little bit of not so, well, I guess it's good and bad news. It's bad news for us and good news for Debbie, but a couple of weeks ago, last week, Debbie Curran gave her notice, and her last day will be next Wednesday. She and her family are moving to Tennessee to start a new adventure there, so she will definitely be missed, especially at the TRS process. She's so instrumental and helpful with that. We're going to try to fill that vacuum and see where we end up. But I just wanted to let you guys know that.
Thank you. And would you say what position she had?
She's the accounting and AAA liaison.
Thank you. We're sorry to see her go. She has been extraordinarily helpful and valuable in our endeavor of figuring out when we say technical, TRS is technical review subcommittee, and in essence the subcommittee that reviews all of the applications for groups in our community to furnish the services that we are required by the Older Americans Act to fund. So it's an extraordinarily sensitive position and very important position in our community. So we really thank her for her service to us as Area Agency on Aging. I hope we get an opportunity to tell her that in person, but we might not, since she's already announced that she's leaving. But I wanted to publicly say who she is and what she does and how valuable she is to us. The next item is the approval of the minutes. If you have any notations or changes for our minutes.
So moved.
Thank you, Jerry.
That's it.
Thank you. All those in favor say
Aye.
aye. Opposed? Thank you. They've been approved. We appreciate it. We have a special presentation today. The Consumer-Directed Nutrition Service, Leanna, from the State Unit on Aging. And Leanna, I'd like you to pronounce your last name, please. I'm sorry.
No, it's connecting.
On? Hello, that's much better. Okay. Yeah, I picked that up when I got married. My parents would have never done that, right? This long first name with that last, they would not have done that. But I told my husband I loved him very much, and then I would take his name. So it's Leanna Konetsky, and I feel kind of, there's so many people to my back, which when you present, that is like a no-no. So I will maybe turn a little bit too, so that everybody feels included. But
It is.
do the arrows? Perfect. Okay. So I am with the State Department of Human Services, and I am the dietitian on staff there. So I'm a nutritionist, a registered dietitian, and I have the great privilege of working in aging. I love working in aging and have for almost 20 years, so I'm excited about that. And I'm here with my manager, who I'm going to point out. That's Todd Coffey. He is our manager of the State Unit on Aging in the Department of Human Services. And so we're delighted to come down and see people today and be invited to come and speak about something that I'm really excited about, and that's nutrition, which is our largest programs under the Older Americans Act. And Carrie was at a training that I gave a few weeks ago and talked about some things there that she thought you all might find interesting as well. So I have a lot of stuff I'm going to cover today in a very short amount of time. So if I go too quick or you have questions, go ahead and ask. And for protocol, can people in the audience ask or not?
Oh, yeah, absolutely.
Okay.
And I would just also add to what Leanna said about my having been in a training a few weeks ago. This is some really dry material, and Leanna brought it to life. And I thought, if there's anybody that can present about nutrition and make it interesting and communicate the content, this is no pressure.
I know, no pressure. Okay.
This is the woman. So we are very fortunate to have a dynamic presentation about material that might otherwise not be quite so interesting. So take it away, Leanna.
What a setup. I will do my best, okay?
Get us to like spinach?
No, I'm not.
Okay.
I'm a liberal dietitian. I say you don't like spinach, try kale. You don't like kale, try red leaf. But anyway, so I really want to talk about some things that are near and dear to our heart at the State Unit on Aging, and that's consumer direction. And we're going to talk about how we've been trying to do a really good job and a real concerted effort to weave that into our programs and our services. And we've made some real changes in the last, I want to say, it's taken, some of these have taken 3 years, because policy and rule changes, it's like a slow-moving ship, right? It just takes forever times to steer it. But I want to talk a little bit about that today. So like I said, we have a lot to cover, but I want to set just a little bit of framework so we're all kind of jumping off from the same spot, and talk a little bit about those policy changes and how we're weaving consumer direction in, and then mention a few things that we are looking at this year that we're focusing some energy on, and that's food waste and malnutrition. There were some handouts at the door. If you didn't pick them up, you can get them later, but I'm going to reference them, okay? So if you're saying, where'd you get those? They're at the door. And then Carrie's going to email my presentation out afterwards so everybody has it. Okay, so I work for the state. Pretty picture of the Capitol. Our office is actually like across the street from it, and I always like to talk about that because I'm a native, and there are few of us left. Do we have natives here? Any other natives? Woo! I just have to say that because it seems like more and more, because it's such a great place, people love to move here. So I work for the Department of Human Services in the state. And within the department, we have lots of different offices, and we are in the Office of Community Access and Independence, and I like to point that out. And we're in the Division of Aging and Adult Services. And our office mission is to foster independence through access to seamless and responsive personalized services. And I think everybody here on the rack and in the audience, that's what you do every day. We're all a part of this network that's working on that. And we have a state office on aging, our state unit on aging. And so we have dedicated staff that care a great deal about the well-being of every older Coloradan in our state, and we have a dedicated group of people in an aging office in our state. Recently, there was some misinformation that didn't even exist, but it does exist, and I like to show everybody we're in the Office of Community Access and Independence. And so We administer the Older Americans Act and state funds for senior services, which should be mostly familiar terms because everybody here, I think, is getting that funding and doing great work with it. The nutrition program underneath that is the largest program. It gets the most money, and with it also comes the most rules. But there is a purpose and intent of that program, and just so that we're all on the same page, it's to prevent hunger and food insecurity among older adults. It's to promote socialization of older individuals. And some people don't like to remember that second bullet, but it's just as important, and every single one of these bullets carries the exact same weight. It's not reduce hunger and food insecurity or, it's reduce hunger and food insecurity and promote socialization of older individuals and promote health and well-being of older individuals, right? Because we're going to assist them to get access to nutrition and other disease prevention or health promotion programs they may need that has resulted in maybe they have chronic conditions and we want to help ameliorate those or help them sustain quality of life. So every single one of those purposes has the same weight, and the intent of our program is to meet every single one of those issues, okay, for nutrition. So to set the framework, what we like to call everybody in this room is part of the aging network. Hopefully y'all have heard that term before. We're all a part of this broad, kind of like a spider-webbed aging network that's across the entire country. It's not just in Colorado and in Colorado Springs, it's in Minnesota, it's in Florida, and we're all a part of an aging network. And the really cool thing I like to point out about this chart, which is just a bunch of squares on the screen, but what is written in red all around it are consumers. And consumers have a huge voice and play a major role in our programming. And I have worked with a lot of other federal or state programs. And what I think makes the Older Americans Act extraordinarily unique and very successful is because consumers is written on every side of it. And I consider it a very local grassroots program. I don't know if any of you have familiarity with some of the other federal programs, USDA, funded school lunch. I mean, there's a lot of other ones. Consumer involvement looks very different in those programs than it does in ours. And that is a huge, huge difference. And we value consumer input and consumer satisfaction at every single level of where we're providing services. And so the Area Advisory Council that's circled, that's you all. You provide input here into funding, into projects, into what the needs are in your local community, and it's extraordinarily valuable. At the state level, we have a commission on aging that's governor appointed from people all across the state where they provide input into aging policy. It's extraordinarily valuable. All the way down to where the services are provided, where they touch the consumer. They have input into what we do, how the services are delivered to them. What they have to say about what we're providing is extremely valuable. And I did not create this National Aging Services Network chart for this presentation. That's how it exists. Consumers are written on every side because what they have to say and the services we deliver to them are very, very valuable. So when I talk about the fact that we have been working hard to integrate consumer direction into our services, it's because it's the intent and spirit of the Older Americans Act that we do that. And so in nutrition, remember when I said we get the most money, but with it comes the most rules? That's kind of the way it comes, right? Usually you don't get a lot of money with no rules. And so we have had a lot of rules in our nutrition program that really weren't the most consumer friendly. Have any of you dined with us at some of our dining sites or talking with consumers? We do when we come out to programs. It's one of our favorite things to do is meet the people we provide services to that you all work so hard to serve. We love to meet our consumers. And probably the most frustrating policy in our congregate dining program that we've had long-standing was the previous practice of forcing people to throw their food away and not letting them take home their leftovers. I see heads nodding. It was undignified, really. It really was. And I can sit here and say that. And what we would hear the most when we'd go out was, why can't I take my meal home? I'm an adult. You're making me throw it away. We're wasting this food. It's unconscionable. So we heard that, and we listened to that. And we made that change. And we made that change because the consumers requested that change. And so we were operating previously in an environment, because when we take federal money, just like when we contract with the AAA here, we agree to rules. Nobody gives money for nothing, right? Very rarely, take the money, do what you want, I trust you. Usually it's take the money, and here's the big book of rules that you're going to follow and agree to. And we were operating in an environment where we were under the impression we could not do that. Well, that environment has since changed, and we decided we are making this change. And so we did. We worked, we heard our consumers, and it was a really big deal. And we appreciate everybody's feedback and the providers that are in the room that were providing this program that had to put up with having people throw away their food and not be able to take it home. So that's no longer a rule. That changed last year. And it changed because of consumer voice and their request to have that changed. And we were able to work with our state health department because, just so everybody knows, when we serve food to people, we are also licensed retail food establishments because we're actually selling it to people. So we have to adhere to the state health department rules too. I know, they just stack up sometimes. And we worked closely with them because we needed to do it in a safe way. Because in the food environment, we serve what is called a highly susceptible population, which pretty much just means that our clients and consumers that we're serving, if we don't take great care in the food that we're providing them, we could end up causing them to become very ill and potentially pass away. It's just a highly susceptible population. So we take great care when we're doing that. So anyway, this is a change that we made to increase consumer direction in our program. So now in our congregate sites, if they don't finish the food at their plate or at the table when they're eating, they have the opportunity to take it home and eat it at their leisure. That's a big change. A couple other areas that this policy change also addresses is it addresses food waste. Because now somebody's going to consume it instead of it going into the landfill and contributing to a lot of other environmental factors. It's not being wasted. We're allowing our consumers to take it home and they can consume it at a later time. It helps with food insecurity because a lot of our diners that come and join us for lunch, that is the main meal of the day. In fact, we know that more than half of the people that join us for lunch report that that's the main meal of the day for them. And so it decreases food waste and addresses food insecurity, which are one of the main purposes of why we're doing the program. So that was a recent change, and I'm proud to say that we made that change and that people are really responsive to it. We've gotten pictures from diners in various parts of the state with thank you signs. It's a big deal. It brings some dignity back to our program, I think, that was lacking. Does anybody have any questions about that? I hope you're seeing it here. Is it going well, Pat? Good response. We're hearing great response. And so that was our attempt of saying we need to make this change, and we care about what the consumers are saying, and we listen to that feedback, and we want to respond to it in a way that we can meet needs. We can't always make every policy change because, like I said, we get stacks that we say, yeah, we'll adhere to that when we do this. But whenever we can make a change, we want to do it. Another change that we made in our congregate program recently, I've dubbed TDCM because it's just this crazy long word, temporarily delivered congregate meals. So what that allows our programs to do that they couldn't do before, and this is feedback we were getting from the programs that were administering the program, saying, hey, we have an issue here and we need to address it. So if somebody comes to our congregate dining center and they're there regularly, but they get sick, and they suddenly can't make it, which is reality, right? Some people get up and they don't feel well that day and they can't come in. Well, what happens to their meal? And even more importantly, are they going to get any nutrition that day? When they're recovering from an illness or they're recovering from a hospital stay, are they getting any nutrition that day? And previously, we would not have allowed anybody to take a meal to them. And so we were hearing feedback from our program saying, you know, that doesn't make any sense. We have this wasted meal. Nobody's eating it. You know, Susie is sick, why can't we take it to her? And so we developed policy that would allow that to happen so that we can respond to the needs of the consumers who would normally be attending the congregate sites but can't get there because they're ill, or perhaps the buses aren't running that day, or the bus doesn't show up, or for a variety of reasons. And so this particular policy change was another big change that we made, and it was based on program feedback. And so this is something else that's happening that you're seeing in the congregate site, so we can be more responsive to consumer needs, and we can, as best as we can, meet that client's need at some of their more vulnerable times, when they're ill and they need that meal and they need that nutrition. And so this policy change, again, addresses food waste, because otherwise we would have thrown that meal away. Sometimes somebody would have eaten it, but not all of the time. And we're getting that nutrition to that person who's in need of it, who cannot come and join us at the congregate site. So it addresses food insecurity, and it addresses food waste.
Is this, you do this through, you just take it to them, how do you afford to the gas to take?
How do we do it? So the interesting thing, which I think is kind of a cool thing about this policy, we let the consumer decide who's going to go pick up their meal. So the consumer can say, my neighbor's coming to get it, or my son's coming to get it, or whomever they choose is just going to come pick it up and bring it to them. So we don't necessarily, the programs aren't necessarily the ones delivering it. It's the consumer saying, my spouse Bill is going to come and eat lunch, and then he's going to bring my meal home to his wife Marilyn, who was ill and couldn't come to the site that day. And so again, because we deal with a highly susceptible population, we worked with the health department to ensure when we're doing it safely. Because we're not going to take unsafe food, right, to anybody who's sick at home. I mean, that would just be disastrous. And so, but the consumer decides who they want to have pick it up, which is another huge change in our program, because for years we didn't operate in that way. So hopefully this is a welcome change. This was provider feedback saying this, where we need a policy, you're preventing us to do this, and we want to weave that consumer direction. And both in the leftover and in this particular temporarily delivered congregate meal policy change, it's consumer driven. And what I mean by that, it's the consumer saying, I'm not going to come in that day. I want Sally to come pick up my meal and bring it to me. Or I don't feel like eating all of this food. I'm going to bring it home and eat it later. It's the consumer making more choices and decisions of what's best for them so their nutrition can be met. Mm-hmm.
What do they take it home in?
So we have containers. We provide containers. Yep, we require clamshells, and we require it to be labeled with dates. Because sometimes what happens with I'm guilty of it. Well, when the heck did I bring that home? So we're labeling things with dates so that we don't have people accidentally or inadvertently eating things that may have gone bad. Or if they have home health. Home health can come in and clearly see when that meal or when that food was put into the fridge. But yeah, we do clamshells, kind of like a restaurant.
I didn't see Ziplocs working very well.
No, we don't do Ziplocs. No. It'd spill, yuck, hot, hard to scrape them out when you're trying to reheat. No, we do like a clamshell. Yeah, and the programs decide what it looks like. But think of like when you go to a restaurant and you take your leftovers home. It's something like that, but we label it. Yeah, those are good questions. Okay, and so then another policy change we made recently, and I always have this slide because, so I've worked in these programs for almost 17 years, and these changes, we had been doing it the same way for the last 17 years. So I use this picture because it's like, oh, seriously, we can send the leftover home? That's how it feels sometimes. And so it's good that we revisit policy. Policy shouldn't be stagnant. It should be alive, and it should be meeting the needs of who are directly a result or benefiting from it. And so we had, for the longest time, within Volume 10, because we have a Volume 10, which is basically Colorado's interpretation of the Older Americans Act. Because what is good for Minnesota, aging citizens, is not necessarily going to work in Colorado, right? We need to be able to craft aging policy for what we feel is needed here and not what they need in D.C. And so Volume 10 is Colorado's interpretation of the Older Americans Act. And then on top of that, we have something called a Policy and Procedures Manual, which is the day-to-day walking out of how we do program implementation. So hopefully everybody's familiar with those terms. But in Volume 10, for the longest time, we said if you're going to do modified or therapeutic diets, and what those terms were meaning is if we're doing specific diets to meet somebody's individual disease state, like if we're doing a diet for somebody that needs a renal diet because they get dialysis and they have to have specific nutrients in there finely monitored to make sure that their blood levels are okay so that they stay healthy. And some of our programs in the States were doing that level detail to do great customer service to meet the needs of our very frail, very, very ill clients. And we were requiring physician prescriptions, lots of oversight, because the therapeutic diet piece, that's a medical model, right? So you have a physician saying, you have a real need here for a renal diet, and I'm going to do a prescription for that, and this program is going to provide it, and so you have a registered dietitian doing a care plan for that. It's a medical model. And before, we had some programs doing what you would consider heart-healthy meals that are not individualized for a person, just we do Mediterranean meals. And we had been requiring that same level of oversight for that Mediterranean meal that we were requiring for that renal diet. And it didn't make sense, right? Why would we do that? It didn't make sense. And so we were seeing programs that were doing this excellent job of customer service to meet the needs of these very ill patients, saying, I can't do all of the paperwork for my Mediterranean diet and keep my Mediterranean diet that you're forcing me to do for this renal diet. And so they would stop doing the Mediterranean diet, which was exactly what we didn't want to see. We didn't want to see programs stop that choice and that consumer direction. And so we realized we needed to change the rules on this. This doesn't make sense anymore, and we needed to change the rules. And it took 3 years to change those rules. And we changed our rules. We opened them up, Volume 10, specifically to fix this particular problem, because we needed more consumer direction. We wanted to clear the red tape as best that we could whenever we can. And some people might be surprised by that, but we love to hear suggestions from any and everybody of ways that we can deliver services more effectively and more efficiently that meet the consumer needs. And if that means policy change, we want to hear that feedback. And all of these that I'm talking about these changes were as a result of feedback.
Alter texture of the food?
Yeah. Yes. The programs have the ability to do that. It's you have to be careful because you're entering in that medical model, and we have rules for that, right, because we've got to keep consumers safe. But yeah, you can do that. So why we made these changes to try to say, I don't think we should be as intense about a Mediterranean diet as we are about this renal diet, is because we wanted to increase consumer choice and direction. Well, like I said, we want to cut the red tape wherever we can, as best that we can, and we were hearing feedback that this wasn't working. So that's what we did. And we made those changes effective February 2016, and we made 2 distinct categories now. So we have those therapeutic diets, which is kind of like that renal diet that I was telling you about, and now we have modified diets, and that's where the Mediterranean would sit. And the modified diets, they don't have to do physician prescriptions anymore, and they don't have to do care plans, and they don't have to have this extraordinarily laborsome oversight because it's not a medical model. The medical model with the physician prescriptions and all of that still exists in therapeutic, and it has to. We have to do that when we're doing individualized diets that are the direct response of somebody having an altered nutritional status because of a disease state or a chronic illness or an injury or surgery. So that stays there. And our modified diets, we liberated them, so to speak, and that is no longer required. And so we're hoping to see more and more and more programs say, we can do Mediterranean diets, we can do heart healthy, we can do, gluten-free that's not therapeutic, because they don't have that requirement of all of that paperwork and all of that somewhat burdensome requirements you find in medical models that are needed and necessary any longer. So we're hoping to have basically eased and streamlined the pathway for programs to do more consumer direction. Because not everybody, when they come to our meal sites, wants the same food. I'm sorry. I don't. And I can guarantee you, as we see more and more individuals age into our programs, they're going to want to eat how they were eating up until that point. And they know what's best for them. So we need to accommodate. Go ahead, Pat.
How does that impact the nutritional guidelines?
Mm-hmm.
Adhering to those guidelines?
Yeah, so we do. We have nutritional guidelines that we adhere to, and we have lots of programs that do vegetarian and vegan and things like that, and they adhere to those guidelines. Okay. Yeah. When you get into the therapeutic diets, you may not be able to adhere to the guidelines, and we have caveats in our rules saying you don't have to, if it's in, if you're on a renal diet, you can't have a lot of potassium. If you can't have a lot of potassium, that means you don't get a lot of fruits and veggies as easily, which means your fiber is not going to be as high. And we say, that's okay, please don't. We're not going to give somebody on a renal diet, yeah. So there's caveats where we allow that movement so that it makes sense, and we can give good consumer direction, and the consumer gets to drive things. So enough policy talk? Are we good? We're real good. Okay. So these are just different things in here that you're going to get in your slides that you can get a little bit more background on, especially that modified or therapeutic. So one of the areas that I personally am passionate about, and I know all of you care about as well because you care about aging, is malnutrition. And that is a real issue among aging, especially in seniors. And the irony is, we're going to talk a little bit about it, is that you would not think in a country that's just as wealthy as we are that we would have this issue. And so we're all on the same page. What is malnutrition, right? And I just put Webster's definition up there. It's basically faulty or inadequate nutrition. And that's really as simple as it is. So that means you can be malnourished if you're just eating Fruit Loops and Oreos and drinking chocolate milk every day. You're going to end up malnourished because you're not getting the adequate nutrition that you need, even though you have food and you have access to food. So malnutrition is not always a lack of access to food. It's lack of maybe access of quality food that is nutrient-rich that your body needs, okay? So we're all on the same page. So the interesting thing about malnutrition is it is a clinical diagnosis. Did everybody know that? We cannot look at somebody and say, the person on the left, because I kind of see his clavicle sticking out, he might have some clavicle wasting, he is definitely malnourished. Whereas the person on the right, I see a fuller face and a fuller neck. She's not. It doesn't work like that. And so malnutrition among our clients is absolutely nearly impossible to distinguish with our eyes. And that's why it's going unnoticed. And that's why it's become somewhat of epidemic proportions, because it is a clinical diagnosis. And we have many, many, many people that are overweight or obese that are malnourished. Does anybody have any idea why?
Fruit Loops and chocolate milk.
Fruit Loops and chocolate milk. Lack of access to quality food that is nutrient dense. And when I say nutrient dense, that means full of the nutrients your body needs. You can develop a condition called sarcopenic obesity. Has anybody heard of that? So as we age, we get something which is just, you can't get around it, where we lose muscle mass. It's just a physiological change with aging. You can't deny it. And in the clinical world, it can get to the point of called sarcopenia, which you get really frail, you fall more often, there's some health conditions where you've lost a lot of muscle. Well, you can be obese and have sarcopenia, and that's called sarcopenic obesity. And that's actually even more at risk than a frail person with sarcopenia because of all the other complications that go along with obesity. But these two pictures, I hope, if nothing else, that you take from my presentation, this piece of malnutrition, you do not know by looking at somebody if they are malnourished. And so you cannot look at your clients and say, a little overweight, she's fine. Underweight, no, he's not. It is a clinical diagnosis, and there are different things, like different potential indicators, and there's a volume of indicators that have to be met in order for somebody to get a clinical diagnosis of malnutrition. But what our programs do, and I think we do well in order to look at malnutrition, is we screen. Okay? So this, determine your nutritional health, this is the only way, unless the client says to you, guess what, I got a malnutrition diagnosis, and there's been studies that show that, and they did a study out in the South where there was a bunch of seniors that came into the ER, elderly individuals, they cut the age at 60 plus. I think it was actually 65 plus, that were getting diagnosed with malnutrition in the emergency room. And do you know the percentage of them that said they had received a previous malnutrition diagnosis? It was like 14%, if that. It's very, very low. So don't expect the client to tell you, I had a malnutrition diagnosis. They're not going to. And don't expect to be able to look at somebody and know we have to screen. And malnutrition is a huge, huge, huge issue in aging. And I put this over here for you. And I know I'm going fast. Sorry. There was a lot of stuff they wanted me to talk about. And it's like super fast. But it's costing this country billions of dollars, billions, billions, and billions, because when you are malnourished and you enter the hospital setting, do you think things are going to go as well for you there? Do you think surgery is going to go as well, that we're going to heal as well? No, we're not. And so it's costing the country, just the aging population alone that's malnourished is like $51 billion in healthcare costs. And the issue with aging and malnutrition is as we age, we have a lot of chronic illnesses, and we take a lot of medication. Some of our clients take more than 8, which is considered polypharmacy, and they are at more risk for malnutrition. And the nutrition that we give our clients in our programs is so important. And like Pat brought up those nutrient standards, we want to do nutrient-dense food for our folks because it's their main meal of the day, but it also helps us get food to them that they may not have access to that's healthy. And so this is they're calling it a crisis. And it really is a crisis, and you're not hearing a lot about it. But this fact sheet, this infographic, breaks it down pretty well. They're thinking that like up to 1 out of 2 adults, older adults, are malnourished, at risk for malnutrition. That's like, let's cut the room here. That's half of us here that are over 60. So when you start looking at our clients, then you have a different perspective, right? If you can't see it when you look at them, but statistics are saying it's really prevalent. I think I've even seen statistics that like 60% of hospitalized older adults are at risk for malnutrition. That is crazy. That's really, really high. And so in our programs, that's why we screen. So this is the screen that we use. It's called Determine Your Nutritional Health. And was this back there, Carrie? Mm-hmm. Okay. So this is a validated screening tool, and it was specifically designed for older adults. Okay? So it's not just a screening tool that was designed for kids that we're trying to make work. No, it's specifically designed for older adults, and we're using it in our nutrition programs. I recommend you put it in every program if you can, but that's the dietitian in me. Because you have to do something with it, right? Because if you're screening people, what the heck are you doing with the data, and what's the point if we're screening and then we're not doing anything? And so this particular screening tool identifies individuals that may be at risk for malnutrition. And then you can plug them into additional services. You could say, I really think you might want to talk to your doctor the next time you're in, or it's great, you have one of the best dietitians in the state working down here to do nutrition counseling, to do nutrition education, or figure out what are the issues that need to be addressed that are resulting in this individual being at high nutritional risk. But we pulled, because Todd is great with the data, Todd pulled this for me. So all the data that we collect, we put into the SAMS database, and we actually look at that data. I like to tell people, I promise it's not a vacuum. We look at it, and in your region, so this is just Region 4, so El Paso, Park, and Teller counties, in state fiscal 16, so that was the state fiscal year that just ended June 30, 2016, we wanted to pull the number of clients who are at nutritional risk, high nutritional risk. So that means they filled out this screening tool and they scored at high nutritional risk. So that means they're at risk for malnutrition. And so only the services that had the data were obviously congregate meals, home-delivered meals, personal care, and homemaker services as well, because as a part of our assessment, they fill out this nutritional screen. So there were 2,446 total clients, right, that filled out the screen. We had 454 that we didn't have any information on. So that's something you guys might want to think about. Are we getting all the information from the clients we need? But 33% of them scored at high nutritional risk. So a third, that's a lot. And that's the people that filled out the screen in your programs on the day that they did the screen. Because not everybody is filling this out consistently, right? Because some clients don't want to do it. But we had 33% score at high nutritional risk. And those that I thought was very interesting when we drilled a little bit down in the data, I always like to look at where we can cut it more, like let's drill in a little bit further. And those between the ages of 60 and 64 and 65 and 74 had the greatest number of clients at high nutritional risk. So you would think it would be 85 plus. In a lot of places it is 85 plus. And please, with this statistic, what I'm driving into the data here, don't disregard that group because they're our most frail. But in your region, 40% of the 60 to 64-year-old clients were at nutritional risk, high nutritional risk. That's a lot. And then when you looked at the 65 to 74, 37% were. But overall, all of those rolling up, you had 33% at high nutritional risk. That's a lot. Mm-hmm.
Did you have a breakdown for ethnicity?
That's a good question.
We can't.
I was curious if you did for that.
Yeah, we were messing around with some of the other parameters, and I forget what we saw on.
We didn't have ethnicity in there, but we can see if we can draw some queries down. Because, and see, that's the thing with malnutrition. Income will put you at greater risk, right? Because if you can't buy food, but it's not food alone that makes you malnourished. It's not just a lack of food. And so this is a great little fact sheet. It's one of the better ones I've seen, actually, where it gets everything on one page, where it talks about it affects everybody in all income levels, because it does in aging. But income definitely puts you at greater risk. But this is a good one. There's some other great, I mean, I could just fill the inboxes, which I don't want to do, but there's really great material out there. Did you have a
I think it'd be, just to piggyback off of what Barb said, I think it'd be interesting to see what our region looks like in terms of ethnicity and gender, because Region 4 looks different than other parts of the state in terms of gender and ethnicity.
Yeah, absolutely. Well, I have to say I was surprised by the age breakdowns.
Where was this taken at?
This was taken out of the data that y'all filled out and put into the state SAM's Harmony system. So we pulled this out of your own data, just so everybody knows. This is your data.
There were questions back.
I was just going to ask if you could read a couple of the non-nutrition questions that are part of that screen.
Yeah, that's a great idea.
Can I ask, what is the frequency of the nutritionist assessment?
So
Is every center doing this for new clients, or how is the process done to get the nutritionist?
So depending on the services, there's different requirements for when an assessment is done. For the congregate program, which is our largest program, we don't require reassessments because it's hard to follow up with each individual that comes in. They might come in periodically. But with home delivered and our personal care and homemaking, we require that every 6 months. So those people are getting updated frequently. The congregate meals, it's usually when they first come into the program.
The screening tool was designed from a research project years ago that demonstrated
yeah, and one of the questions what Todd had brought up, because like I had said, this is designed for older adults, and we know, I always say as a geriatric dietitian, we're actually also social workers, because it's not just nutrition. And so you'll see on the back side, it's called the determine because it spells out how many drinks have you had. So let me read a couple of the other questions like Todd was saying. I have 3 or more drinks of beer, liquor, or wine almost every day. We have a lot of our older adults that actually do a lot of drinking of beer, liquor, or wine, and we need to know that because that does interact negatively with some medications, but it also impacts whether or not they're eating well. I have tooth or mouth problems that make it hard for me to eat. We know dentition is a huge issue for nutrition. I am not always physically able to shop, cook, and or feed myself. So those are just some of the ones. I don't have enough money to buy the food that I need. I eat alone most of the time. We know through research that older adults, when they eat by themselves, don't consume as much as if they're in a group setting, which is another reason we have congregate programs. So these questions are far-reaching because we know as geriatric practitioners, as gerontologists, we know, right, that there's a lot more going on that's impacting our client than just potentially cooking that food and eating it. There's a lot of other issues that may be at play that need to be addressed. And it's not so easy as a dietitian. Buy more fruits and veggies. It just doesn't work like that. So I don't say that I am. I just say we have to have access to other resources, and no.
I was just
Yeah.
thinking about your comments that we're kind of social workers. Some of us really are social workers.
Okay, note taken.
When you, when you cook for one person, that has a lot to do with it. So what do? They go in, they get a banquet,
Yeah,
pot pies, whatever.
yeah.
I don't know nutritionally how that is, but that's what a lot of them do. And eating by
Yeah.
yourself
Yep.
is probably one of the biggest.
It's challenging. It's very challenging. We hear a lot of people say, I just don't have the desire to cook anymore. It's just me.
I'm not there at that latter part of age, and just cooking for one person. If I do, then I have all this food that goes in the freezer, and then when okay, I'm hungry, so you pull whatever out that you made buku of because you're accustomed to cooking for a lot.
Yeah, yep.
So there's a lot of that going if you have the food to do it.
Yeah, if you have access to it. Yeah. It's complicated. It's really complicated. And that's why I say as dietitians, geriatric dietitians, it's not just about food. There's all these other ancillary things going on, and you have to understand that and know how to navigate and access resources and things like that.
How big of a factor is it that highly processed food is cheaper than fruits and vegetables and
Sure is.
stuff?
Yeah.
It seems like that's
Yeah, it does. And there's actually something called, has anybody heard of the obesity paradox? Why for the longest time, we were seeing people that were accessing food, like at food pantries and things like that, have higher rates of obesity, and it was because of the lack of nutrient density that was available at those pantries. It makes a huge difference. A huge difference. Some processed food is better than others, right? But access to nutrient-dense food, that's why the meal programs that you all are providing and working with and referring people to, they are really important. They are really, really important. And they have those purposes that we don't always talk about, but they're really offering access to people healthy, nutritious meals that they don't necessarily have to pay for, right? They don't have to pay to get them. It makes a big difference. And the uniqueness between our programs and SNAP, which is, formerly food stamps, is that we're giving them a prepared meal.
Where they pick.
Well, they don't have to go to the store and buy it and cook it. It's prepared. It's fully prepared, and it's ready for them to eat. So,
It'd be interesting for you to know that the gerontologist that I see, Jeffrey Culp, he had me fill out one of those when I went in for a 6 months checkup.
that's great. I'm so happy to hear that.
To watch my gait. I was really surprised. I've never seen, that happen before.
That's good, your nutrition. I'm so glad to hear that. That's fantastic. I am very glad to hear that.
I'm curious in audiology. So I spend quite a bit of time talking to people about their lifestyle and what's going on. The thing that I hear the most that people need outside of what I'm there providing for them is dental health. And since I'm seeing these people, I would really like to know exactly what should I tell them. I hand them the yellow book. I don't know what else to do. I don't know if that's the thing that I should be telling them. I've got the 2-on-1 cards out for everybody. But dental is the crossover complaint that I hear the most often. Then vision comes second after that. So, it would be nice to know what resources I should have available.
For dental?
To help people with those things.
We don't do anything for dental.
Well, I know, so the AAA may not do dental, but one of the best things ever for those that receive Medicaid recently is there's a dental benefit included. So if the client has Medicaid, they get a dental benefit, and it's $1,000 a year.
$1,000 a year, and if you need dentures, that's not included in the $1,000. So the $1,000 is more for the maintenance and cleanings and things. If you need dentures, there's a provision to provide dentures through the Medicaid program beyond that $1,000. And then
You
there's
go
the other
ahead.
program. There's the low-income senior dental program through Medicaid. That's for people up to 200% of poverty, and there should be at least a couple of providers in the Colorado Springs area that's participating in that.
So let me walk back my comments. When Leanna looked at me for a long time, some of you may know and some of you may not, this agency ran its own dental program, and that's what I was saying when I made my comment. That was the program to which I was referring. But we do fund Senior Mobile Dental to do hygiene and some minor dental procedures using our Title III funds.
And does Senior Mobile Dental, they're a Medicaid provider and they're a low-income dental provider. So
That's correct. So if we funnel people to them, they know how to access the different programs. And I think it's fair to say that Pat Ellis's case management team at Silver Key is also aware of that local resource.
Are there like cards, brochures, something that I could have?
Check with me after the meeting, and I'll see what we do have, and I can also send an email to Michelle Vaca and ask her if I can connect the two of you so that you can speak directly.
And if I might just piggyback on that information, Senior Mobile Dental has a van that has an X-ray machine in it, and they take it to the nursing home or to the congregate place wherever. I'm not aware that they take it to the individual homes. I'm not saying that because I don't think they do. That's right, they don't. Okay, so, but there is this capability of even having the X-ray. Totally up-to-date, modern. It's great. And they have, to answer your question of mobility, which you didn't ask, I'll answer it anyway. They have a lift on their van that you can sit in and lift up to the van and then get to the chair, turn around, come back, and go down. So it's fully accessible.
They've also moved their offices over to the senior center area now, where before they were on the, it was inadequate to get there. Transportation was a big issue, and now it's at the senior center where that resolves a lot of the transportation.
So that's, and that chair, that lift chair on that van, is part of what they ask for through the Area Agency on Aging budget. So our budget provided that piece to them. So I think that's, although we don't do what we would like to be able to do, it is important, and that's not a part of it, but we do have some hearing kinds of things that we help with. So there are, and vision, I don't think so, we don't have anything. No, we don't have anything.
Not anymore.
Okay, so anyway, that's to expand that answer. Thank you for your time to let me do that.
That's good. Dental is a huge issue, so it sounds like there's some really good resources down here for clients. So last but not least, one of the other areas that we're focusing on this year is food waste. And so, you know how we made those changes to that leftover program and to allow consumers to take leftovers home, but then to also be able, if they so choose to not be able to make it in, they're ill, to have someone bring a meal to them. We're also looking at ways that we can reduce food waste. It is a huge problem, not just in our programs, but globally. It's not just a wealthy nation problem. It's a global problem. And we are really starting to push and look at our programs and say, where can we, any place that we can cut waste. Waste isn't good for anybody, but the bottom line is when we're throwing food into the trash or it's not being given to somebody, it's actually hurting our programs because we're still paying for it. And that's maybe somebody down the line that's not going to get a meal because we wasted a meal over here. And we don't want that. Nobody wants that. And so we are going to be focusing, and one of the great things is Pat Ellis here with Silver Key, they're already ahead of the curve. They have a great working on the grant, as it ends in December, doesn't it, Pat? To really hone in and focus on that, because it is a large issue, and it's not just at our congregate programs, it's also in our home delivered meal programs, because food waste happens all along this line. Are we buying too much? Whoops, I forgot that stuff in the back. I didn't rotate my inventory. Shoot, I didn't mark it. Now it's bad. I got to throw it away. Or I'm really scared we're going to not have enough when we get to the congregate site, so I'm going to send an extra 15 meals. Or, you know, Joe said he didn't tell me he wasn't going to be home. Darn it, I went to take his meal. Now what do I do with it? And so it happens in all areas along this path, basically, and we're going to be focusing more and more on that. And so I just wanted to give kudos to Pat and Silver Key in your region for stepping up and saying, you know, this is an issue, and we need to try I'm from the country, take the bull by the horn, so to speak, as best we can, but it's something we're looking at on a statewide basis. And so that's something that we're encouraging all programs to do, even down here, is to really audit that whole line. Where am I purchasing? How much food are we wasting? And in the business of food service, sometimes that's a touchy subject. But so that, again, is something else that we're looking at because we don't want to have waste. Mm-hmm.
You have that, you ever think about the people on the street?
Mm-hmm.
If you have the...
To give it to them?
Mm-hmm.
You know, I know some programs do that. And when I say some programs, some USDA-funded programs do that. I don't know how we would feel about that. We haven't tossed that around, and I don't know if we, when I say we, the state, it might be a federal decision as to whether or not we can give it away. I'd love to have our clients eat it.
That's very true, but if you have the extra, that's what I'm saying, you've got all these veterans and everything else out on the street. You know, if you have the extra and you don't want it to go to waste, then that would be...
Yeah, I appreciate that feedback. Yeah, and that's something I haven't looked into. I've seen other areas do that, like that are funded with USDA. Sometimes when it gets kind of a sticky widget when it's like, well, who paid for that and what's happening with it? But yeah.
If you want to go to waste, it doesn't matter.
Yeah, well, I'm hopeful that we don't cook extra food. That's where I'm hoping we hit it on the production side. But yeah, I appreciate your feedback, and we can definitely look into that. Absolutely.
Because you got all the people that do it for all the homeless and everything. They come in and it's just helping out.
The gleaning
whatever.
programs.
Oh, right.
Yeah.
With produce, do you guys compost or anything like that?
Some places compost, some places do. The problem with that is if there's not a bigger facility to take it, or if you're not utilizing it, if we don't do it well. But some programs do compost. And so, I mean, we have no problem with people composting. I'm hoping that we have very little compost because I'm wanting to tackle it on that purchasing, storage, and production side as best we can. Yeah, but we do have some programs that compost, and this is, so they have a food recovery hierarchy of what is the most preferred and best way to deal with food waste, because it's not just that it goes into the trash, it has a huge negative environmental impact. And so we want to keep it out of the landfill if at all possible. But composting is one of the, it's better than it going in a landfill, but that is one of the lesser desired outcomes, because if it's not handled correctly, because ideally we just don't serve it, we don't prepare it, and we are not putting in the labor and the time, and we're not buying the food if we're not going to feed it to the people that it's intended to go to. Does that make sense? So this is in the presentation too. So this is the food, basically, recovery hierarchy, and this is the broad perspective on how to handle food waste. And this is issued from the Environmental Protection Agency. So you guys have that in your resources as well. Any questions? There was some great questions while I was talking, and I so appreciate that.
It's kind of like a restaurant. You cannot guess the public.
Thank you, Leanne. This was
Yeah,
very
sure.
informative.
Thank you for the opportunity.
All right, we have no action items today, so we are moving on to our information items. Our first provider is Sarah Lipka from the Colorado Legal Services here in town, and thank you so much for being here and for what you do, Sarah.
Oh, thank you. I brought my questionnaire. Did everyone get a copy, or I can pass them out too?
I'd be happy to pass them out if you want to give them to me. There you go.
Let's take one. Which one is it?
How much time would you?
It was a...
Oh yeah, I'm a lawyer.
These are duplicate of what we already have.
You got
You
it.
have it?
There were the...
I didn't get it. Can I get one?
See,
Oh, no, I haven't. Yeah, they're not.
Okay, so I printed them in black and white.
Yeah, that's okay.
Who didn't get one?
hey,
Can I get one? Thank you. I know.
somebody came in.
Anybody in the audience? They were printed in black and white on the table.
I was in Europe for the first one, and then I had a medical thing.
Must be nice. Okay.
My name is Sarah Lipka. I'm the managing attorney at Colorado Legal Services in Colorado Springs. I've been in the Springs office for a year now. I'm looking forward to meeting you.
Use the microphone.
Oh, yeah. Okay, can you hear me now?
Perfect.
Sorry. All right. My name is Sarah Lipka. I'm the managing attorney at Colorado Legal Services. I've been there for a year. If I haven't met you yet, please come up and talk with me. I also had a baby last year, so I was out for just a couple months, but now I'm back. Baby's good and ready to forge ahead. Colorado Legal, I want to talk a little bit just about Colorado Legal Services in general, so you know what we do, and then I'll leave lots of room for questions. So Colorado Legal Services is a nonprofit organization. We get a lot of different funding sources, including funding from you, so thank you very much for that. We're also a law firm, so we have to follow the rules the lawyers abide by, as well as nonprofit rules. So that our mission statement is to provide meaningful access to high-quality civil legal services in the pursuit of justice for low-income persons and members of vulnerable populations throughout Colorado. So we are always trying to help as many people as possible with the resources that we have, but also provide really good services to the clients that we take. So it's always a balance because we can't help everybody that needs our help. We try to help as many people as we can, but balance that with actually providing a lot of in-depth service. So we give advice and brief service to folks, but we also do a lot of full representation. And for our seniors, we try whenever we can to provide some level of service whenever possible. So we make the seniors a priority for our office. Statewide, there are 50 attorneys and 32 paralegals in 13 offices. I think I have a map. That's a map. If you can see where all the little stars are, that's where our offices are. So it's kind of hard to see, but our office is down on South Nevada Avenue. If you ever want to come by and visit, it's a beautiful historic building. It used to be a boarding house and an apartment building, so I think it has some character. I'd love to give you all a tour if you want. Let's see. So since there's only 50 lawyers, we try to do our best, as I was saying, to help as many people as we can, and also to do full representation whenever possible. Legal Services has been in Colorado since 1925. I think the oldest program that we had was in the Denver office. It's been in the Springs for, I want to say, since the 70s is when I think Legal Services in the Springs was created. In 1999, a couple of different programs merged so that we are now one statewide program. We have a board of 27 members with 18 attorneys, and then we also have financially eligible individuals on our board, so low-income folks on our board as well. We have 63 different funding sources. Legal Services Corporation is one of our largest funders with about 40% of our funding, which is more for our low-income folks. We also have the Legal Aid Foundation, which does fundraising for Colorado Legal Services. I think this is a good statistic. 85% of our funding is expended for direct delivery of service, so we're not spending a lot of money on management and things like that. Types of law that we do, we focus on civil law. If there's a criminal case, we usually refer people to the public defender. We don't do fee-generating cases because a private attorney could do that. So if you are in a car accident and you want to sue the other driver, you can hire a private attorney. If you have a good case, usually they can collect their fee when they win. So we don't do those types of cases. We try to take the cases where somebody would really not be able to find a lawyer who would want to take it. So that would include a lot of family law. More than half of the people that come to see us, including seniors, request assistance with family law, dissolution of marriage, legal separation, civil protection orders, custody cases, health and elder work, so that would be public benefits, We help people with Medicaid, Medicare, food stamps, different types of programs if they're terminated inappropriately or if their application was denied inappropriately. We can represent folks in those types of hearings. Some of our offices represent people in Social Security cases. Right now, we don't have an attorney to do Social Security cases in my office, but I do like doing those cases, and hopefully we'll be able to start doing those again soon. Let's see, unemployment and benefit appeals. We have a paralegal right now that's doing unemployment work for our clients. We have our migrant farm workers division out of Denver that goes across the state in the summertime to do outreach. We do a lot of housing, I think, after family law. The biggest need is in housing. So in our office, we're doing public housing and private housing. So if somebody has a defense to an eviction, we'll take those types of cases. Also, sometimes we can help at least give advice or sometimes call the landlord if there's a problem, like the landlord won't get rid of the bed bugs or there's some type of retaliatory eviction because somebody's complained about the bed bugs or that the door won't lock. Unfortunately, there's, like everywhere across the state here, there are some landlords that are not, don't treat their tenants well, and so we try to step in when we can in those types of cases. And then utilities and consumer cases. So debt collection cases. If you have a debt collector that's harassing you, we can give you the information so that you can have that debt collector knock it off. If you have a defense to a debt collection action, like you haven't paid on your debt in over 6 years, they shouldn't be able to collect it from you, or you don't actually owe that debt. We take those cases. That happens more than you'd think. We also try to help with identity theft. We can help people process that. Other types of consumer issues, fraud cases we can help with. Yes?
Will you take on ADA cases?
Can you elaborate a little bit? What do you mean?
What with the American Disabilities, maybe somebody, well, like one of our patients that we had was quite profoundly hearing impaired.
Yeah.
And he was in an apartment and there was not smoke detector in there that had visible light. So something like that.
Yes.
That would require the landlord to supply that or any number of things.
Yes.
Whatever.
We would take those cases, especially if it's public housing. Then we can really hold the landlord's feet to the fire and make them get in compliance. It might be a little bit more difficult with a private landlord sometimes, but public, yes. Yes?
Work with a family that maybe it's an elderly person who has dementia,
Uh-huh.
and maybe their adult child who is trying to obtain legal oversight, but neither of them have any money.
Right. So right now, we are fortunate because we have a volunteer attorney who's retired, who's in our office part-time, doing estate planning, which I think is really helpful. I think it prevents elder abuse. I mean, I see so many folks add their kids on to the deeds of their house. Instead of, they think it's easier than doing a will, and then the children say, oh, I own the house, I think it's time you go into a nursing home. So I think estate planning can prevent those types of problems, so we can do that. We do sometimes do powers of attorney, but you have to be competent to sign the power of attorney. And I don't always do powers of attorney because I think that those can be abused so easily. I know Silver Key helps with guardianships, right? So we should work more about that on that. I do like doing adult guardianships, but right now it's not one of our priorities because Silver Key is doing a good job with that. But between the two of us, I'm sure we can, if you call me, we can try to figure out a way to help that family. Yes?
Your answer to the question of Pikes Peak Area Council of Governments funding, what stuff do you do that's non-funded by us? And it's kind of just a repetition of all
Right.
your previous stuff. Does that mean your funds that you get are just intermingled and they all go to the same services?
No. So for our funding for this grant from you, we can help seniors regardless of their income and assets. So we're able to help people that are not low income.
Okay.
And so we try to help as many people as we can. We have our legal services funding states that we can't help somebody that's over 200% of the federal poverty guidelines. It's usually 125%, but we can go up to 200%. And then we have asset limits. We do target our services to low-income seniors because we can't help everybody. So if I am looking at two seniors' cases and somebody is having a problem with a $1 million trust account and somebody else is having a problem with low-income housing, I'm going to help the person with the low-income housing because I think that that other senior might be able to afford an attorney. But we don't have to cut people off. I guess we did have a foreclosure defense grant that just expired, so we could go up to 250% for the foreclosure defense grant. But we have the same, in general, the same intake priorities for our seniors as we do as low-income folks, except that we do the estate planning for seniors in my office right now. And those priorities were, my office looks at them about every couple months, and every so often we do a needs assessment, and we look at the needs assessment to see, what should we be doing. So based on the needs assessments, usually most people are coming to us for family law, and then housing, and then I would say consumer after that.
What percentage of your funding comes from us?
I don't know about the percentage, but I remember the amount that you gave us. So our annual budget is for statewide is about $9 million, and that is not the amount that we spend in our Springs office. That's for all the programs. And then we get about a little less than $44,000, I think, from you, which is very helpful. I divide that between time from, I have a consumer attorney who has about 10 years of experience, and so he takes a lot of senior cases for landlord-tenant and consumer work. He actually just did a federal fair housing case and one for some seniors. And then I have in my office two younger attorneys that have, one of them has a year under her belt and the other one has 2.5. And they're primarily focusing on family law, but I'm also training them on some consumer. We do bankruptcies sometimes, mostly for utility shutoff purposes. If somebody's about to have their electricity shut off, sometimes we can file a bankruptcy which would prevent the electricity from being shut off. That's an emergency, so we make those a priority. So within my office, the funds go to help with part of my time for the casework I do and the other attorneys, as well as the resources to supervise and give a desk and a computer and a phone to our volunteer attorneys. In addition to the estate planning attorney, we also have a volunteer attorney who's been in our office about 7 years, and he does a lot of consumer, and his specialty has kind of become mobile home evictions, so I give him those ones too. Yes?
And I may be wrong remembering, but I remember working through your proposal in the TRC.
Yes.
And at that time, I think you indicated that you were having a challenge hiring lawyers and additional legal, and that was where it was difficult to ask for increase in funds. Has that improved?
Yes, it has. So last year, I used to work in the Pueblo office, and I got hired to be the managing attorney here. And one of our attorneys in the Springs office lives in Pueblo, so she took my spot in Pueblo. So we were down an attorney for a couple of months. But fortunately, an attorney from our Grand Junction office wanted to live in the Springs, so she transitioned over. So now we have 4 attorneys, which is, we've been at that level for a couple of years. So we're not we could always use more staff, but it's not as critical as it was when I was writing that grant. And then also, we've been really lucky to have that volunteer attorney doing estate planning. That's providing a good service to seniors. So we're actually right now ahead of schedule with our funding. We're able to provide more units of service than we have before. So, and I think I've also tried to make our senior grant a priority, and as well as our consumer work. I think that consumer and family law are both very important, and so I want my attorneys to do both. Does that help answer? Okay. Okay, all right. So the types of services we provide are full representation, legal advice. So full representation would be, like, I'm going to represent you in your divorce through permanent orders, as an example. Legal advice would be have somebody come into my office, talk with them about their legal problem, give them advice about what they can do, write a letter outlining my advice, and then closing the case. A brief services level of assistance would be having somebody come into the office and I help them fill out maybe some of the pleadings for a case, but I don't enter my appearance on the case. And then we also try to make appropriate referrals whenever possible. So because so many people would like our help, as I said before, we're really trying to focus on basic life necessities. I'm trying to take cases to keep people in their housing, free from violence, with access to public benefits. Those are the types of cases we try to focus on. And I think that it's good for my attorneys and it's good for the community for us to do as much full representation as we can, which means that sometimes we can't give as much advice, but I think it's good for professional development and for the clients for us to take people and represent them in court when we can. So I wanted to give some examples of our clients that we've helped lately, and we have obviously a lot more, but I just went down my hallway and asked some folks to tell me about cases they've done lately. I think that the estate planning has been really helpful for our clients. They feel relieved. So we had one woman who met with our volunteer attorney who, and I changed her name, was upset because she was getting a lot of different feedback about what she should do with her estate planning from different members of her family, and feeling pressured from different members of her family. And she was saying, I want to be buried in a different state. And her family was saying, well, we're not going to afford that. You're just going to have to deal with it. And she really wanted to be buried in her family, I understand that. So she came in, we helped her do not only a medical power of an attorney and advanced medical directive, but I think we also helped her with a will. So it clearly laid out what she wanted to have happen, not only when she gets sick, but what should happen down the road a long time from now when she passes away. And she felt a lot better after that meeting. She felt empowered. She felt like the meeting helped her organize her thoughts about what she wanted to do with her estate planning, and that she was able to, through the paperwork that we drafted, effectively communicate that with her family, which I think will probably, hopefully, end those stressful conversations with her and let her family know, this is what I want, this is what you're going to do. So that happens a lot with our estate planning folks. This was a family law case for a senior that we just completed. A woman was severely abused by her husband. I think he probably would have killed her if she hadn't got out. So in addition to the physical abuse, strangulation, pushing, punching, it was a very controlling relationship. We got her a civil protection order, and then we got ready to do her family law case, and we learned that he had never gotten around to divorcing his first wife. So we did an annulment instead, and sometimes it's tricky, because if you're not supposed to be married to two people, who's going to get what? She was determined to be the punitive spouse, which is a good thing. So that means that she was entitled to, we got her some maintenance. We divided up the marital property. So she's going to have money to live on now from that long-term relationship that she invested so much in financially and emotionally over the years. And for her, she really wanted to keep her animals. He was also very abusive to the animals. And because she wanted the animals, he wanted the animals. So we got to keep the animals, which is I think that means a lot to her, so I'm glad that we could do that. So we have a lot of cases like that, actually. We really try to focus on helping folks who are survivors of domestic violence, because I think it's harder for them to represent themselves in court. So we try to help those folks. As another example, we had a client who lost his Social Security card. He didn't think he needed it. And then he wasn't able to apply for benefits after that. Somebody stole his identity and was using it to work. So it was a big mess, but we were able to sort it out. So we have a unit in our Denver office that focuses on ID issues. Sometimes we refer those cases up to our Denver office, or we'll do those in-house. So that's an example of the type of work that we're doing. Here's my contact information, and I think that was about 15 minutes. Any questions? Yes.
On your clients, do many of them, can you give us a sense of how many are walk-in versus referred by another agency, another organization?
Yes. So we do outreach, I think, at about 6 different locations. So a lot of our clients and a lot of our seniors come from our outreach.
That's local here?
Local. We go to the senior center here. We go to Woodland Park, Fountain. We go to Cripple Creek. We do an outreach at the courthouse. There's one more that I can't remember. Sorry. So a lot of folks come from the outreach. We do have walk-ins. We also have people call in, and we are working on setting up a centralized phone intake system. So if somebody calls in for foreclosure, consumer, or housing issue, then it goes through our statewide system, and those folks should be able to get advice or assistance a little bit faster than they were previously. So I think it's been helpful. If we had a consumer case come in that none of the attorneys in my office would be available to provide representation for, that person will at least get advice relatively quickly now through the phone intake system. And let's see. So I don't know. I think it's not all. I would say we also get referrals from Tessa on a daily basis. So I think most of the cases that come in to my office come in through phone intake or referrals or outreach, but we do have people walk in every day.
Sort of another question. Your comments say that you have some problem areas, so if you had extra money or additional funds, what are those problem areas that you would like to work here?
Well, for example, I would like to help people with SSI appeals. We're not able to do that right now. I'd like to help. There's a lot of types of consumer issues where we're providing advice, and I wish that I could provide full representation in those cases. We could take more cases. Let me think. We could. I'm thinking of my protocol list and the types of cases we've had to exclude. I think a broader range of consumer, and we would take more housing cases. We're always considering only doing public housing, but so far we're taking private as well, because I think that they're both equally important. Once you have an eviction on your record, it's really difficult to rent. But if you lose, if you get evicted from public housing, then you might lose your Section 8 voucher, which is just, it's devastating to the clients. So.
Okay. All right.
Okay. Thank you.
Thank you, Sarah. We appreciate it. Thank you. Carrie and I have had a little conference here, and would the audience like to take a break? Would we like to have a little 10-minute break? Okay, let's do it. 10 minutes, and I'll call us back together.
They do is they're doing family history. To take the children, and they a lot of these kids, they don't have any background.
Sarah.
Those calls, she's the agenda.
Yeah, that's great.
In this case, look.
You bet.
I'll bring that up.
So we're just wondering.
She said, oh no, that's not, that's what they're going. If they would be able to take the child. And if not, then what they do is they create a family memory book, which is something I'm familiar with doing. So that child knows going to be able to belong to something.
That's Colorado Springs.
And I was very impressed. I had
Colorado Springs office, the seniors that we
Do
call
they include the medical history, which could be so critical to the child's later on in life?
I don't like that. Yeah, I would hope they do, but I didn't
Things that you work would be Social Security.
Because that seems to be the biggest source
Yeah.
by a lot of these adopted children want to find their family. Because all of a sudden they've developed, you know, their benefits. So I'm term limited and I have to.
No, that's terrific. I don't remember her mentioning
and
that,
it breaks my
but
heart
it
when I have
could
to.
be because she was focusing her task
Do you also
to
put
find
an
the
hour
family members.
limit on how much service you can provide to
I
a particular
haven't fit
senior?
in the schedule yet, but I was
Because some of those would be very complicated. I can see where you're doing it. Staff, which might impact the ability to serve.
Yeah, and I've always, it's a balance, and I struggle with it because
wrote that down so I wouldn't forget.
I just give advice to everybody.
It was just kind of fun to be part of it.
And then
And,
a lot of seniors walking
and to
away.
have found something that they didn't have. And it was just an obituary, but it the family name and stuff like that.
Well, and you can do so much now with computers.
The one she was working on at 6 years old. I just thought, I could take grandson.
On the agenda is, as you can see, Lisa Alderman is going to talk about carryover funding TRS meetings. So what I'll do is get your availability as chairs, and then work with the doodle poll function and schedule a
What are we
couple of
looking at?
meetings.
What time frame? In early November?
Sometime in November. It doesn't have to be early, and there are certain steps that staff has to take here before we're ready to meet. But she's going to just give some preliminary info, and then some of you will not be able to. I also want to give you the opportunity to chat with them about spending and if you have any questions. I may have to bug out and see if the meeting's over, then we can talk on the phone or if you want to come back in the office.
Yeah, I would like to do for our senior section. Forever.
Joe and Joe.
Sure. Well, so many folks, they don't want to get their grandson in trouble. But I think similarly,
Let me, once Joe is back from out of town, he and Lisa and I will look at what work needs to be done, and then we'll know
Okay.
the earliest we'll be able to start meeting. Our next RAC meeting is going to be December 8th, and that'll be the potluck. And we'll present the work at that point, so we have like a 6-week window to work with.
Okay. All right, thanks, Gary.
Yeah, thank you, Dave.
So you're here.
2 years of pantry food and listening to all of the issues, you know. I have a blank form. That's right. Now I have to fill it out. But I looked at it this morning and I thought, oh, I can handle this. I just have to sit down and do it, right? Right, right. How long have you served? Oh my God.
Is that part of the
Oh, really? You have to take a year off? Is that how that works?
The reason I'm focused on that, monumental manager is very interesting.
Right. It was interesting because I was going to
MCSS.
focus on gerontology, and now I
I wanted to be near home. So there's a good difference in somebody who,
But it's still a matter of, okay, we need
and then a general practitioner.
dialogue to try to come up with a longer-term solution for what the patient needs. Camp evidently is
Where are your parents? I didn't grow up. Those are my two first grades. So it's a big deal. You're awfully raised.
I think they asked that. They said, you got that.
Well, and see, my background is trained teacher and special ed. There is a relationship between special education and seniors that is, in the sense that you know so many people walk in the front door here and they cannot tell you where the problem is. Everybody uses that. Ask the right questions, you know. And, okay, here are 2 three choices. That's the one, you know.
Yeah, 2 weeks.
Wow.
End of July, yeah. Ireland for a week, and then went to Somerset, southwestern England for a wedding for 4 days, and then Germany to see my 91-year-old aunt.
Pretty close. And
So it
sometimes
was
I
pretty
can't
much a
remember the
whirlwind.
last time I never changed.
Great weather, no rain. Cruise?
All that, it was just awesome.
Yeah.
Passport, that's 9 yards, but it was really fun. You didn't have to go by yourself, it's not, I guess they got the single ones.
Yeah.
But I know you haven't been around.
I don't know of that one.
I'm surprised you did that. I wrote it.
It says PPACG.
So,
So it's monthly, is it like on Thursday? With the chairs.
It's mail, and how do you get mail? It's hard. And if you want something free, you can't enter into conversations with you.
But you're not, oh, you're still on the email.
And you listen to your phones. I problem solve that way too. Yikes. But anyway,
Yeah.
so I'm just saying myself.
Yeah, what I'm seeing is that I did a quick scan through the PPACG and looked at the various committees and stuff. I'm seeing that, okay, monuments basically not there. Exactly. And even if there is not active discussion of it, they still should be privy to what's going on across the area. Is our voice.
I don't do that anyway.
Exactly. That's what the town manager's got.
Betsy ought to have to come back and do something. I've never forgotten sitting on that.
Catholic in there. See today what our Pope said?
I know, it seems like it.
I don't know.
We got something going on in our center today. We invited a bunch of agents.
Peggy, come back
Mary's
together,
sitting here
please.
thinking about getting a little speech ready for that. And once I run back.
I understand.
Or they can mingle and I can shout.
Just start in, Mary.
I know.
I probably need to make it. I would have been very.
There's been a change in the agenda. Ted let me go ahead of him. I'm Mary Barrowman with Prospect Home Care and Hospice. And what I want to do is kind of give a whole top-down understanding of what it's like to do business up in a rural area and the complex medical model. And that's what Prospect is. Prospect's been around for almost 35 years. It's a 501c3 community-owned, which means there's no stockholders, no individual that just made a not-for-profit or a group of individuals, but the citizens of the UTS region own Prospect Home Care and Hospice. And I have been their CEO for 13 years. So I can probably talk for 15 or 5 hours here on everything that we do. So here's what I really want to communicate on the difficulties. As we provide 3 highly regulated, very sophisticated, complex medical delivery businesses. We do the home care, we do hospice, and we do Helping Hands, which is where our Title III Older American Act funds go. And in our Title III, as you can see on my report, we do telephone reassurance and homemakers PCPs. So all 3 of my different divisions are separately admission requirements, paying requirements, discharge requirements, documentation, certification, licensure, you name it. And what's a challenge for a rural area is we do it for so few. Last year I had 31 hospice patients. It's a huge amount of work to provide everything that a hospice patient needs for 31 patients. And as you can see with my Helping Hands division, the numbers that we're taking care of here. And what we do successfully with Helping Hands is delivering the personal care, homemakers, and telephone reassurance. The 82 telephone reassurance is an amazing benefit to Teller County. Every time we do our annual surveys, peace of mind, saved my life, brought the helicopter, allowed me to stay independent in my home. I have been here for many, many years showing you the pictures, showing you the faces, and showing what a good benefit being able to deliver the Older American Act into a rural area. Because everything we do has too small of volumes. There's no competition up there because it's not a good business plan. I lose money and have always lost money on every single division. So I probably lose last fiscal year, $2,000 per hospice patient. And when we work on the money that contributes to the matching of the AAA, that's because of the grants I write. And that's the other thing with my shared rural providers here in the room. When you have low staff with low volumes, low census, you do everything. There just isn't anything. There's just that we wear every hat is just an a priori. It's just how it has to be. So in 13 years, I came to this position with 35 years healthcare executive experience. So I was fortunate to have a lot of background, a lot of regulatory. I've been CEO for a for-profit, for not-for-profit. I've been corporate compliance officer for a Washington, D.C. system. I was lieutenant commander in the United States Navy. Since my time there, I have not spent one nickel on an attorney. I represent everything. I write every single policy. I'm a policy freak, as Carrie and Lisa might know. So it's not just Volume 10 for me. It's Volume 10 for just the Older American Act, plus the federal ones, plus what home care is, plus what hospice is. The admission packet for home care is 25 pages. CMS just came out with a new ruling on how they're changing the questionnaire. So I printed out the 380 manual, and I'll be reading that to make sure that we deliver it right. It's just very, very difficult. And then what we all do is our small businesses is everything else. I do HR. I make the health insurance policy connections. I do my own 990. I have auditors come in every other year just to save money, because every year I can't afford it. We're a $1.2 million company. I get about $80K from AAA. In that $80K, I have now used to solely deliver a unique, precise product. Over the years, I made many mistakes. We will call those learning lessons, where I tried to expand it to more, do more, do 2-hour visits and this and that, and it's not feasible. The travel time alone is a nightmare. The fact that you want to strip a bed and wash the sheets and clean the kitchen and get somebody in and out of the shower can't be done in under 4 hours in the mountains, because they do not have wash machines like we do, and the well does not pull water fast enough. So with that, my excellent full-time personal care provider is out in the field for 4 hours a day, two a day. And we can't bring everybody on, because a lot of people we have on are there for quite a few years, because we can't pull out. You can't have someone who waits every Wednesday for their shower and their vacuuming and their shampooing and say, well, not your turn anymore, we're going to bring on Joe. So there's not a lot of turnover. I addressed in here that I don't do a waiting list. I'm tired of doing waiting lists. You know, I can find people when I have an opening in a heartbeat. I can call Aspen Mine, I can call Teller Senior Coalition, and so we keep onesies and twosies, because I don't get that many openings for my delivery of personal care. The telephone reassurance, we market that, we put them in as quick as possible, and we monitor that really well. But having people call me every month to see where they are on the list is not good public relations. So I don't do it. Another thing I want to really ensure that you know how valuable you are is how we have changed and grown over the years through your reimbursement. The fact that we're able to put more of our costs in and have that return is paramount for me to deliver this program. Medicaid HCBS pays nothing. You know, they pay in the state of Colorado about $15.50 an hour. They just came out with a national ruling on it that the average reimbursement for Medicaid for personal care in the home was $13.43. And to the government, I say, shame on you. You are lying, saying you're giving the seniors a program. You're not. Because if you're going to raise the minimum wage to $12, knock yourself out. I pay my person $9, and I can't think about it. It's burden, it's transportation, it's health insurance, it's days off. You know, so I limit the Rocky Mountain options for long-term care Medicaid, because there's only so much I want to lose on each case. And it's across the board. My business has never made a profit with their revenue. We make the gap up with grants, fundraising, and donations. I almost brought you the graph, but it was too depressing. And I'm disappointed Carol isn't here, because Carol Parks is the chairman of my board, and then she could throw in her opinions and perspective, because she's been on my board for quite a few years. And I'm a tough leader. I'm a strong leader. And it's just tough what we do. I have fabulous staff. Last year, as I addressed a little bit on the phone, my long-term Christine, who used to be here with me, she moved on. So of my 7 in-office staff, I had 3 replacements. And I have to train from everything. Nobody comes to me knowing how to do home care billing, hospice billing. Don't even get started on SERVs. You know, so everything's complex. It's just what we do. We do it well. And thank you very much for giving us the funding to be able to have the citizens in a rural area access federal programs, because most of the time we're neglected and we're given excuses on how it's too expensive to care for us. Any questions?
On your reassurance, if I did the math, and it's 242 service units per client. Explain that. There's 82 clients and 19,000 service units. That seems a lot, but I'm sure you can explain it.
Well, I don't know if I can, but I think that's the way it has to be. Those numbers in units, I think, are 15-minute increments or day increments. In the PERS, they're day increments. So every time, so I have 30 days in a month, by my 80 people. When we do a telephone reassurance, we do a call out once a month to test their phone and talk to everybody. So that's just the formula that the AAA gods have us use. That's what, they define the units. I call everybody who funds me a god. Because they do whatever they say to get that money.
Does that make sense, Carrie?
Where's Lisa?
She's right back here.
Yeah.
Lisa's the one who can speak to this far better than I.
When you do the math for reassurance clients and divide the service units by that, I get 242 units per client.
That's correct, because a unit is the client having access to that service every day, plus the call they make once a week.
Okay, because that math kind of works out to every weekday in a year. Is that about right? Yeah.
That's about right.
Yeah.
Yep.
Okay. Thank you.
I put in the number. I didn't get to do that. They fill in the number.
Okay.
Yes. Absolutely. I do. I worry about it all the time because I did come to the position with unique background. And but in the transition, in the hardship transition of losing 3 of my leaders in the last year, I was able to hire a younger woman, which was great because all of us were like, as you can tell, about 40 or maybe 60. And there were too many of us in the 60s range, and so we use this opportunity now that when I was able to do the replacement, I have a young woman, she's just a child at 35, unfortunately, who's still fertile and is out pregnant with a baby. But whatever, so it's kind of miserable for me for the next 3 more weeks or 8, I don't know, but that's why there's no PowerPoint or nothing. I'm just glad I'm standing here. And but she has really good experience. She was a home care executive before she came here. She has the desire to have my job, which no one has ever had before. And so we're looking at the 3 to 5 year plan, and there's a lot of requirements on what you have to do to train a replacement for a healthcare administrator now, because there's never enough rules. And so we're working on that together, and I really hope it works. And so how we know it'll move forward, and Carol would know this too, is no one will be another me, because it would be unique to come in with that background. But how will we delegate it? How will we identify the strengths in Amber? And then will we outsource grant writing? Will we do this? Will we do that? And I was leaving early today because I have a conference with the IRS on my 403B, which I totally do. So no one else is going to do those things. It's just stupid. I was just lucky. I don't think I'm smarter than anyone. I just had a really varied background. Decided to reside in Teller County, and Prospect needed someone with my expertise.
Mary.
Yes, ma'am. No. We become licensed and certified. The volunteers come and go and they fade away because you have to have 12 hours of education and training. You have to have the background checks, and they're too undependable. There's too much churn. We tried that too. We do required by regulations to have 5% of your revenue in hospice has to be done by volunteers. So we do invest in the volunteers that are in the patient home, and have massage therapist as the most desired volunteer in hospice, and because they do hand massage, foot massages, and chair, shoulder, and at this time too, we happen to have a harpist that lugs her huge harp, because she's a tiny woman, into cabins and everywhere else to play harp music. Yes.
I don't think there's anybody's going to take your place.
Thank you. No, I like to work. I like to work, and
There's a nice question about the succession thing, but first of all is to keep Mary here.
well, and I'm very community oriented. I'll do whatever the community needs.
Other questions?
Thank Thank you.
And thank you for making time. Oh, wait, stop, we have one. Lisa, I'm sorry, we've got one emergency request. Lisa needs to, she's got she's back up to another commitment at the moment, so I'm sorry. You were very kind.
All right.
Do you want me to pass anything?
No, okay. So, before we go, I have two, right?
Can you move the mic so that it picks up your voice?
Hello, I'm Lisa Aldridge. I'm the Program Services and Contract Administrator for the Pikes Peak Area Council of Governments Area Agency on Aging. I like to joke that I'm contractually obligated to say that when I introduce myself. It's not exactly true, but kind of. Maybe we can. I have to find a new joke. That one's not getting as many laughs anymore. So, recently, we received from the State Unit on Aging our numbers for carryover. And at the last, I'm not sure what APAC stands for.
Aging Policy Advisory Committee.
Thank you. They had a meeting, and our numbers were released at that meeting, and this is one of the spreadsheets that shows how much of our federal money that our region did not spend. That's what the red percentages are. And just a little bit of background, we have funding that's divided into federal money that comes from the Older Americans Act, and that's what all the Title IIIs and the parts and the OMBs, all of that's listed there is federal money. We are able every fiscal year to carry over up to 10% of the federal money that we get in our initial budget allocation. State money is another funding stream that comes from the Older Coloradans Act and other what's called long bill funding. That money, we are able to carry over none of that money. So our strategy every year is to spend our state money first. We were able to do that, so we did not leave any state money on the table this year. It wasn't easy. We had to juggle some expenses to get it done. It was down to the wire, but we did it. However, that left a lot of federal money on the table. Part B are our supportive services like transportation, assisted transportation, case management. C1 are your congregate meals, nutrition education, nutrition counseling associated with congregate meals. C2 are home delivered meals and the associated nutrition education and counseling that goes with that. Part D are your evidence-based programs like the YMCA provides for our fall prevention program. Part E are family caregiver services. Administration, that is Carrie, Joe, myself, and a couple of other folks that use that money to keep things up and running. Then we have elder abuse and ombudsman. So as you can see, all of our admin, elder abuse, and ombudsman money got spent. There was a lot of leftover in the congregate meals, and a lot of that was due to the fact that when Golden Circle transferred over from the Housing Authority to Silver Key, the cost for meals went down dramatically. So that was the good and the bad news. Good job. And then for our total overall carryover, the average came out to about 37% that we didn't spend. So we're going into carryover time, and our technical review subcommittee is going to be looking at proposals. So I would also charge you with maybe looking at some strategies to make sure that we don't leave any money on the table if we can avoid it. And I'm sure our providers would have some input on ways that we could do that. And we will get information from Debbie about our run rates before we start looking at that. Joe and I are meeting on Friday to set up a schedule to put out the request for funds. I would like to use Oasis to do the carryover requests like we do for the request for proposals. So we'll be talking about how we can do that. So that would involve our chocolate software folks. And then, of course, we have obligations that need to be met with the state with getting what we award into the state budget on the benefit system that they use. So that's what we've got coming up. And now for the actual figures that we're going to be working with. Do you have any questions at this point before we move on? Yes,
How quickly does that have to be spent?
It has to be spent by June 30th, 2017. Any other questions? Dave?
Does that figure or that percentage compare with last year on the carryover?
We're number one. Oh, not how does it compare to last year. That, I don't know the answer to that. I didn't have a chance to crunch the numbers.
It was lower last year.
It was lower last year.
A bit lower, yeah.
It was quite a bit lower last year. That much I do know. How much lower, I don't know.
Lisa, Todd's
Yes.
got his hand up, and he might actually know that answer.
Do you know that, Todd?
Yeah, so last year, we have a 10% limit on what you can carry over.
Right.
And anything above that, we redistribute. Last year, we didn't have to redistribute any, so Region 4 would not have had any part over 10%.
Okay.
So that's a big difference.
Difference, yeah.
Yes. Bobby?
From just a comparison standpoint, the cost per unit shift made a huge difference in how this played out. So your historical numbers had to do with the way reimbursements were done, and the current numbers are a reflection of having that whole transition. So it's not.
That's a good point.
It's not just a numbers calculation, but that adjustment period severely impacted this.
So to give everybody a little bit of background that might not have been following all of the action, year before last, we were using an actual cost reimbursement system. And then last fiscal year, 15-16, we switched to a cost per unit system. So I think a lot of the reason that we were leaving money on the table last year had to do with the learning curve with that system. And I think we have learned a lot, and we're still making adjustments this year. So I expect it will be lower this year as part of that learning curve, and next year I would hope that we can see it get back down to what it was when we were doing actual cost reimbursement. Because everybody's been in a learning curve. Providers are needing to learn how to do their budget to make sure that their CPU is accurate. Because with an actual cost reimbursement, they just provided us with the invoice for the expenses, and we reviewed the expenses, made sure they were appropriate, and gave them the money that they spent back. So getting the money that they spent back in a cost per unit system requires a little more of a thought process to get that done. But I think, Bobby, or do you feel like you guys, Mary, or is Mary still here? No. Are you guys getting a better handle on that now?
I think that it's more understandable now than it was at the beginning of last year. But if, in the past, if there was money in a grant, you could access it if you were providing service. The expenses are a cost of doing business. But in the cost per unit reimbursement, even if you had money in the grant, if you did not have the units to be able to recover that, it sat there, and you could not impact whether you got that out or not. There was no later readjustment of the cost per unit or anything like that. So from a provider standpoint, if you do that on an individual basis, it's a small piece. But from a region-wide basis, when you have lots of little pieces that are sitting out there that can't be recovered,
It adds up.
that's going to have this kind of impact.
Right. Okay, so this is, any other questions? Okay, so this is what we are looking at for this year. I highlighted the points that, or the columns that are the most important, but I'll still go through this. Here we have our title parts again. The 16 initial estimated budget amount, that was what we got at the beginning of the year on July 1, 2015. This is a carryover amount that we got last year about this time, which was based on how much was not spent in 14-15. And here's the total of those two columns. This is what we spent. This is what we didn't spend. This is what we were allowed to carry over. And this is how much we're getting this year in the carryover. Now, in the RFP process, there were some funds that were not awarded due to an oversight by admin staff, not Carrie or Joe. That would be me. That still needs to be awarded. So I added that into the carryover. And there's also a pool of program development money that was set aside for us to do something similar to what we had done under Guy's direction in 2014. And we'll tweak what Guy did because we did learn some lessons through that. So there's going to have to be some parameters around that. And these are the totals that we're going to be awarding in the carryover process, and the total being $134,735. So the providers, you can look for request for proposals-ish, because this carryover funding will only be made available to current providers for the current services that are being provided. It's not like our RFP process where we open it up to everybody. So you can be looking forward to that. There is going to be a tight turnaround time that happens every year. This year isn't any different. And the TRS, same thing. You'll be getting the proposals to read and review, and their tight turnaround time to get those recommendations to the RAC and then to the board and get the state what they need. So we're going to have to hit the floor running with roller skates on. Any questions so far? So the pink column is what we're looking at redistributing. Yes.
Does that mean that you're not taking any new RFPs, but the ones that are already given funds, they can request more funds if they can justify?
Yes. The question was, does that mean we're not accepting proposals from new providers for new services only to current providers and current services? And the answer to that question is that is correct.
So what is the time frame that the current providers need to up their services so that they can access this money? What is that time frame?
That money needs to be spent by the end of this fiscal year, which is June 30th, 2017. Was that the question?
Well, what is the application time? Say, for example, Silver Key wants to do more transportation, and they say, well, we're going to transport 50 more people at X rate. When do they have to have that to you?
That's what Joe and I are going to be meeting about on Friday, so I don't have the answer to that question. But the application process for carryover is much shorter. There aren't as many questions. So having a tighter turnaround time isn't quite as involved. I don't know the answer to that question. I have to meet with Joe first. Yes, Pat?
On the C1, it shows there's a final carryover allocation, but total to award is 0.
It shows that none of it was awarded there was nothing that wasn't awarded at the RFP process for any of the meals programs.
Yeah, go to the first yellow column, Lisa, and the third cell down. What that shows, Pat, is that everything was awarded at the initial RFP.
No, I mean the pink column.
Oh.
Pink column.
So if you look at final carryover allocation by part.
Oh, that formula is not right.
Okay, good.
Good catch.
And that's doing the same thing on the other.
So it'll be
meals.
59,668.
So I will fix that formula. Sorry about
Does
that.
that make sense? Yeah.
I had not finished my first cup of coffee yet. That's my story, and I'm sticking to it. But I will send out a corrected and revised version of this to everybody, so you'll have correct numbers. That'll go out to the RAC and all of our providers. Sorry about that. I love numbers. Yeah, it's not so much. Yeah. I got a degree in psychology. I didn't realize how many numbers I would be inundated with, but.
How's that work?
Well, I just counsel myself by talking to myself, so I save money on getting a counselor.
She gets what she wants.
Exactly.
So the pink column in the end will be the bottom number, the total. Is that likely to be the carryover allocation plus the funds not awarded at RFP?
And the program development money. Yes.
So that's going to be a much bigger number.
Yes.
Okay.
So, yes, I did that formula completely wrong. So I will fix that. It'll be more money than that.
All right.
Any other questions?
If not, let's.
Lisa, all you did
move
was
on.
grab the 2 yellow columns and
Missed, yeah. So, that's all.
That's easy.
Yeah, so it's going to be 218-ish thousand more dollars than what is down there. I thought that number was awfully low when I said it, but, so.
Well,
Now I know.
Now we caught all the colors and the numbers, and we'll move forward.
Okay, great. Thank you. Very good.
I would like, it's, obviously the TRS is going to get a lovely invitation to, we got to get together, gang, and when can we do it? I would also like to renew the invitation for all other RAC members to come in and observe and join the group, because next year we will be having another TRS, obviously, another TRS committee, and the more times you look at these charts to see what's going on, the easier it is for that committee. So I just put out that little caveat and that invitation, and it's very sincere. You may not become a voting member of the committee, but you certainly will become a valued member of input, okay?
And I do just want to give kudos to our TRS and our RAC. I think we have one of the most thorough technical review processes. Each one of our TRS members puts in an awful lot of hours. Just reading proposals during the RFP period, each TRS member put in about 8 hours. Two meetings that go at least 3 hours, maybe 3 meetings that go 3 hours. Then there's the carryover, each meeting. And then we have the carryover process. And I just can't imagine a better scenario and a better thought-out recommendation to our RAC and to our board than what we get in this community. And I just want to say thank you for your dedication, passion, and hard work. We do really appreciate it. Thank you.
We appreciate it.
Take care.
Thank you. Community of Caring, our very caring Ted. Thank you, sir, for being patient.
So we don't have the synopsis sheets, we're going to just pass around a copy of the PowerPoint if you would like one.
We sure will.
So I'm Ted Borden with Community of Caring Foundation, and we operate out of the Aspen Mine Center. We had a great ability to visit with the RAC in August and had a great time up there, and I was thrilled that everybody came up, so thank you for doing that. I wanted to speak really briefly about the Aspen Mine Center and then also pretty briefly about the Senior Advocate Program. The Aspen Mine Center is in Cripple Creek. It's a one-stop shop community center run by Community of Caring, a 501c3 nonprofit. We are based in Cripple Creek. Our mission is to provide quality services to residents and families of Teller County while promoting the values of respect, responsibility, trust, caring, and family. Community of Caring works with dozens of agencies. You heard Mary Barrowman speak, and we love Mary. Mary is high energy, very involved in the community. We love working with Prospect. We also love working with Colorado Legal Services, with Peak Vista. So we have about 22 agencies that operate out of the Aspen Mine Center. We have a significant high percentage of seniors and disabled in Teller County. And that seems a bit ironic because we are a rural area, obviously, and we really have a lot of challenges in Teller County, things like transportation challenges, but people that are really hidden in some of the most rural areas, the mountain communities, and so we have a lot of challenges with the senior program because of the accessibility, people being unable to access some of the services, and so really there's a lot of outreach, there's a lot of time that goes into providing. I'm not sure why this is doing this the way it is, but we'll just keep clicking. So there's a lot of time that goes into outreach with our seniors, into case management with our seniors. There's a lot of complex and multiple needs with our seniors. They're also a very proud, very individual, kind of a hard-nosed population of folks. And so sometimes the last thing they want to do is reach out to, for services. But Rebecca Blair, who is generally doing this presentation, does a great job of reaching our seniors in the community. So one of our big accomplishments is strengthening partnerships. We really pride ourselves on collaboration and on integration of the services that are available in Teller County, and we have a very active group of volunteers through the Aspen Mine Center that provide about 7,000 volunteer hours per year. A lot of those hours go towards helping our seniors and our disabled population. So strengthening partnerships in the area to make sure that we're keeping seniors as independent as possible in their homes. We have a lot of seniors that have more than one issue, so comorbidities, and trying to reach out and get more home community-based service providers that can actually work with seniors over the long period of time. That has really been key to allowing some of the seniors in our community to stay in their homes, is through HCBS and the CDAS program, people actually being able to care for them in their home for a significant number of hours. We have an employment center in the Aspen Mine Center, so we get people that are looking for caregiving opportunities, and so that becomes a great opportunity, and it's a really great program that we help to coordinate. Also, helping to increase like I was saying, the HCBS and CDAS employees in the area, so partnering them, making sure that some of the seniors have access to all of those services. That's what Rebecca is so good at, is providing them the options counseling to know what kind of resources they can access, helping to coordinate those, and then really being able to cut down the amount of other services that they will need by providing in-home care.
Would you go back to the previous slide?
Sure.
In the last bullet, there are 5 different contractions, and you explained 2 of them, but what is, I've been in this committee quite a long time, and I still don't know what RMO is and AMC and PCP.
Oh, Rocky Mountain Options for long-term care. So they're the provider, they're the organization that will determine if a senior is eligible for Medicaid services or for HCBS services in a community.
No, it's AMC.
AMC, I'm sorry, that's the Aspen Mine Center. Yeah.
Okay, and then PCP?
A primary care physician. Sorry, she should have given us a glossary with all of the... Anything else?
That's it.
Okay, thanks. So we, just as an example, and I'll say this very quickly, but we have a senior who had huge barriers. She was estranged from her family. She had been in our community for a very long time, very active in our community, but she started having a lot of physical issues as well as some beginnings of dementia. we were able to pair her up with someone who could come into the home as a home community-based provider. So they were able to provide her with reminders on taking her medications. They were able to go with her to doctor's appointments. They were able to go with her on the shuttle to make sure that she got to and from one appointment to the next. She is now thriving. She absolutely loves this gal who is providing her the services. But those types of things, Rebecca was able to initiate the contact with this gal, but now the gal is actually providing great services to this individual, and so it's saving a lot of organizations a lot of money, a lot of time, just because this individual is able to provide 20 to 30 hours of direct care in the home for her. So a lot of times being able to expend a small amount of money for Rebecca to be able to provide options counseling in the long run saves the community and saves other organizations and a lot of time and resources in the end. So one of the other programs that we offer is Energy Outreach Colorado funding through the Aspen Mine Center and Community of Caring that can actually help with utility assistance, and it can also help with our staff at the Aspen Mine Center can also help with filling out LEAP applications. But Energy Outreach, if we provide some upfront referrals for individuals to be able to get things like propane when it's a lot cheaper through the summertime, so they're filling their propane tanks, and propane in Teller County is huge, as well as firewood. And so putting some effort in the beginning can actually help the seniors over the long term to save and be able to budget their money more effectively. So that's one of the other programs that we provide. And again, that's Energy Outreach numbers there. Some of our challenges, the rising number of clients that we have with mental health challenges and with addiction issues, or both. So we do referrals to Adult Protective Services. A lot of times, Adult Protection will actually not work with seniors who have addiction issues. And so that is one of our greatest challenges right now is clients with significant disabilities, mental health issues, dementia, who may not have family available to help and may not also be ready yet for something like a guardian. And so there's a lot of challenges in regards to that. Again, addiction issues. Living in a gaming community, one of the other issues is gambling addictions, and we have seniors that will spend their entire Social Security checks on gambling. So that can be a significant issue. We also have in the Independence Center, was here, Dixie's here, there's a great head injury support group that's available, and about half of the people in that group are actually seniors. So that exists in the Aspen Mine Center as well. So there are a lot of issues in that regard. We're seeing a lot of transient of folks come to Teller County. Not a huge number of those are seniors, but it is significant enough to be a concern. We talked about the need for dental services, and Senior Mobile Dental also comes to Teller County, to the Cripple Creek, to the Care Center, and to the Aspen Mine Center. And so that is still one of our challenges. Certainly it's been better because the Medicaid is able to pay for some of those services that they didn't used to be able to cover. But dental we still consider one of our challenges in Teller County. Some of the programs that are not directly funded by PPACG but are benefiting our seniors in the area. We have a great veteran service officer, Mike Bartol, who provides a great service there, and he actually helped to coordinate a veterans event back in May that was really successful. Also, we have a meal program on Wednesdays. from 11:30 to 1. And we have about half of those folks are seniors, so about 30 to 35 folks are seniors, but we also have a lot of people with disabilities there. We have some community people that just show up, like police and fire department. And so we serve about 60 to 65 people every Wednesday at the Aspen Mine Center. We absolutely love partnering and collaborating. That's one of our greatest strengths at the Aspen Mine Center. We have a lot of fun. We work very hard to coordinate services not only for our seniors, which is what Rebecca is so good at, and we are a relationship-based organization, so we work with people over a long period of time to make sure that they have the services that they need so that they're not falling through cracks and gaps. We also do community risk factor analysis every 3 years through the build-a-generation process to identify areas that we need to address that are risk factors and that are gaps in community services. So I know I've gone very quickly. I know we're running out of time, but are there any questions in regards to some of the services that we provide at the Aspen Mine Center and some of the things that Rebecca does through our Senior Advocate Program? Yeah. How many paid staff? So we expanded a bit this year. We have one of the things I wanted to speak about really quickly, a financial health advocate program that's partially funded by United Way. And a significant number of our seniors need to sit with somebody and really work on budgeting issues because they're on fixed incomes a lot of times. So that is one of our new programs. We have a food service coordinator for our food pantry and our commodities distribution, all of that. So we have 13 paid staff. We have 6 that are full-time. Any other questions? If you haven't been up to the Aspen Mine Center in Cripple Creek, when you're up visiting the casinos or looking at the scenery up there, stop into the Aspen Mine Center. I'd love to give you a tour. So thank you so much.
Thank you. The visit at the Aspen Mine Center was really a highlight for me personally. I just felt the warmth and the joy from the people that were there. It's very welcoming, and thank you.
Thank you so much.
Peak Vista Health Centers, Kristen, thank you for your patience as well. Sorry this has gone long, but the information is excellent, and we look forward to your presentation.
Well, thank you. So I'm Kristen Ackor with Peak Vista Community Health Centers, the Audiology program. And with me today is also Marianne Hamilton, the audiologist. And we're the team that makes audiology happen, along with Grants, and Chris Breyer's here as well to answer any questions that you might have about that. So with the audiology program, the main purpose is to supply hearing aids to those that have no other means of obtaining them. We also can do some minor adjustments, hearing tests, things like that. And one of the things that always comes up is the waiting list. And first, I just wanted to thank you so much for the funds. We actually, for I think maybe the first time, have the smallest waiting list ever. And it's 3 months, which is phenomenal. And the only reason for the wait is that we can't schedule people out 3 months just because of things that'll change. Marianne actually comes down from Denver, so there's a lot of things like that. And as we get into the winter months, there's weather. Any time that there's snow in the forecast, usually people will call and say, well, it's supposed to snow, I'm not coming today. So those are some of the things, but I did want to explain the process, and that might help the understanding of the waiting list and why we can't see 30 people in 1 month for hearing aids. Currently, with the way the grant is, or our contract, we can do about 5 people a month for hearing aids this year. And how that process works is we will call them, schedule them to come in. If they have not had a hearing test done anywhere else, we can actually do that through the grant if they don't have another way of obtaining that. So then for them to come in for that hearing test, that's about an hour to an hour and 15 minutes. And then from that hearing test, that's where Mary Ann will look at that based on their hearing loss. If it's just a normal hearing loss, their primary care physician needs to sign off that they are medically cleared for those hearing aids. Sometimes there are concerns that are identified where, based on that hearing test, which Mary Ann can explain far better than I, but it might show something. There could be a brain tumor, there might be something more going on, and that's where they would then need to see somebody else first to address that issue, make sure there's not a larger medical concern, and then they could get those hearing aids. So say we're talking about somebody who just has normal hearing loss. So they come into the office, they'll have that hearing test. Mary Ann will talk to them about their options, what kind of hearing aids they may be able to get, and then we will ask that provider to sign off on that medical clearance. Working with providers and other organizations sometimes can be really challenging. There's a few places now that when I call, they're like, oh, whose is it? Because we need that back. And once I receive that medical clearance back, then we can order the hearing aids. So from that first appointment, best case scenario, it's 2 weeks that they can then come in for follow-up. Usually it ends up being about 3 weeks. And that's when we would order the hearing aids based on that clearance. Order those hearing aids, they then come in for their follow-up fitting appointment. That also lasts about an hour to an hour and 15 minutes. That's where Mary Ann will go over everything with them, run tests on that to make sure that they're hearing correctly and so forth. And then they will, again after that, then have a 2-week follow-up, because being in the office is one thing, but going into the grocery store, being with your family, in the car, there's so many other things where those hearing aids will need to be adjusted, and Mary Ann will ask them to keep track of their questions or issues that they have. Somebody once put a battery in upside down, and when they came back to that 2-week appointment, that's where they said, well, these hearing aids don't work. Well, the battery was in upside down, and that's an easy thing to do. They're this big. So, well, smaller than that. I can't do it how small. Yes, wee tiny, yes. Exactly. So in theory, once they've had that follow-up appointment after the initial fitting, they should be good to go for about 3 months to 6 months. And then they'll come back in, meet, if they have tubing or so forth, Mary Ann will change that out, because the tubing will get hard, and wax and things like that will block it up. And then they come back again at right close to their year time frame, because we can send those hearing aids in under warranty, no cost to them or the contract, and they will do a complete overhaul on those hearing aids. So they're basically good as new. They replace the microphones, all the components in there, making sure that that person then has a working hearing aid. And there are still people that we see that have been part of the program since before it came to Peak Vista. Years ago, yeah.
Back in the day when it was at Easter Seals.
Yes.
And it came to Peak Vista 7 years ago?
7 or 8, yeah.
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 In the beginning of fiscal year '09, because we finished, it was housed in early '09 at the original Easter Seals chapter, and when that fiscal year was closed out on June 30th, then you guys started up on July 1.
It was here.
Yes.
I was here for a while.
Yeah. So that's pretty cool.
So that's a really quick explanation of the waiting list and why sometimes it seems like the process is long, because it is long and it is cumbersome. And a lot of times people will call and say, well, I have these old hearing aids, or my neighbor gave them to me, and you do repairs, can you just fix them? Well, no, because now with technology and everything like that, hearing aids are on a specific software. So there's only so many places that we can have the specific software with that we can update those. And places like Belltone and things like that are very, very specific. Yes?
When you get donations of this of hearing aids from people, what do you do?
Those actually get sent into the company called Starkey, and it's called a salvage credit, and they are able to salvage those. I don't know what pieces they use, how they can use them, but they do give us a credit for those. And then when we have somebody that comes in whose hearing aid is out of warranty, and or maybe they still like it, or it was one that was given to them by somebody and it just needs to be recased, we can send in those hearing aids, and with those funds and the Starkey salvage, pay for that to be done for that person. So the donations do still go back into the program in that Starkey salvage. So, and then Mary Ann's going to tell you a little bit about some interesting things.
I am going to just piggyback on that, something I was going to say later, but I'll say it now since you just asked the question. The salvage account, we used to have over $1,000 in it, and we've dwindled it down to nothing. And I would, on my wish list is if we could have a box in your lobby that people could donate hearing aids into. I'd like to put a box down at our senior center down south as well, because working or non-working, any kind of hearing aid, we send them in and we get those credits. So I thought, I've dreamed it, I think it would be a nice, like, Boy Scout, Girl Scout type of a project if somebody could come up with just a nice box that we could, and because they're kind of grimy in that. I mean, it needs to be something that they're dropped in and then nobody can stick their hands in there and get at them afterwards, some sort of secured little box. But if anybody has an idea, would love to have at least 2 of them. I don't know if we'd be able to do it where we're at because we're combined with CU there. So, but anyway, thank you for having us here today. And I just want to tell you how much we appreciate the funds that we've received, and I want to pass along from a number of people that we've served a huge, huge thank you. I'm often said, please tell whoever provided the funds for this, thank you, thank you, thank you, and oftentimes with tears. It's an emotional area for us. We have a number of people that are so grateful. And I want to thank you for the funds that we've received, extra funds this year for something that I had requested. I've been seeing people more and more as our population ages. We're getting people that have multiple problems, and visual problems, neurological problems, arthritis, and they just cannot do the battery thing. So we requested some extra funds to buy rechargeable hearing aids for those people that we feel really are in need of that. And I brought a little sample of what we're looking at. So our hearing aids come from a company named Phonak, and there's another company that has come out with this. It's called Z-Power, and it's just a little rechargeable battery pack. And there's a hearing aid that Phonak has that then is compatible with the power pack, so people can just set their hearing aids in there and get them recharged and not have to do the whole little battery thing. So
That's huge, especially with the elderly. I mean, it's really hard.
Oh, it is. It's so difficult. So thank you so much for approving our extra funds for that, because it is, Phonak has supplied the hearing aids all along for this program since its inception back in 03 or 04, whenever that was. And they have been fabulous. They've upgraded since I started in 07, and I think it was 07. The hearing aids that we had at that time have been upgraded 3 times. We have a new one this year that they're providing us, and it's just wonderful. They've gone into wireless technology, and they're providing us with one of their lower end basic hearing aids, but it's still it can work with a remote control. There's some people that I see which will it's probably a request down the road, is that if we have somebody that needs a remote control because they're not able to do the controls, In the past, I couldn't ask for that because the hearing aids that Phonak was giving us weren't compatible. This year, just in last January, they upped us to a new hearing aid that is compatible now with a remote control. So that's something that I've been thinking in the back of my mind needs to come up.
You mentioned the Starkey, and you're mentioning Phonak. What hearing aids are you talking about?
So Phonak has always provided us with a deep, deep discount for a hearing aid that we use for the program. Okay. It's what, maybe 65, 70% off of their wholesale. Nobody gets that, except for maybe Costco. But Starkey, we also have an account with them. Back when the program was housed over at Easter Seals, there was another program provided that used Starkey hearing aids. So we've traditionally kept with Starkey, but we use them now primarily just for our repair because they have an all-make repair facility, whereas Phonak does not. And so that's why we have that.
And Starkey comes with a 1-year warranty too when they do that.
Right, yeah. So and we did, for a short time, we did a couple of Starkey hearing aids, but Phonak has really been our go-to. And we do have a contract or an account with another hearing aid company, but we've not used them since I was actually housed here a number of years ago. So that's, and here's some brochures on, if you want to pass those around, on the rechargeable hearing aid. So that's the big thing this year is our hearing aids. They're fabulous. The other thing that we've been doing, and I think we mentioned this last time we were here, that we were starting to do this, was because of our waiting list, we really felt we needed to get people vetted out on really how needy are they. Because, like the older Americans guidelines doesn't really put, of course, have hearing as a separate item. So we felt we really needed to get these people in that really were in dire straits. So one of the things that we do is we do encourage them to send in a hearing test with their application. If we've got that, just see right up front, wow, this person really needs our services, not next year, but this month. The other thing that we're doing is in our application, we now have them fill out a self-assessment of how they are doing in their environment, in their world, with their hearing loss. And we can actually score it on a scale of 0 to 100% on they have no disability, no handicap, all the way to a severe problem, not being able to really function at all with their hearing loss. So those two things have really helped us to get people in that need to get in. And this is our application, but the top page has the self-assessment on it. And I'm always tweaking things in that area. And I can pass that over that way. The other thing that I already talked about was my wish list, which is, again, to try and collect more hearing aids so we can get our salvage account back up. So, again, if you know anybody that has hearing aids, any way to collect it. The other thing that I was just talking to Ted about this before we started today is our sound booth up in Cripple Creek at the Aspen Mine Center. We used to go up there monthly, and it really became somewhat cost prohibitive. We just weren't seeing enough people. I think hearing loss, it's a disability that lends itself to a lot of apathy and procrastination, and we would get up there thinking we were going to see X number of people, and we'd see one person. So Kristen and I have tossed around our sound booth idea. I was just talking to Ted about it. We'd like to move it to maybe a Divide or somewhere where we could have people from Park County come in and still have the Teller County people, but we don't know where. Peak Vista has a medical facility there. There's not enough room for a little sound booth.
It's not little.
Well,
What about in the Teller County Public Health Department? They have an office in Divide. Aren't they right by where Peak Vista is located?
I don't know.
Up behind the Venture
And see, I don't
Foods?
know, and I don't know the size of these places.
Did Ted leave?
He did.
Oh, darn. I thought he was still here, so I was sort of scanning the audience looking for an answer.
Because we have everything is portable that we have. So if we could just put that to use in a better way. I know we don't get a lot of Park County people in, and we've discussed maybe twice a year doing screenings over in Fair Play. Something that we could be more useful in those counties and using our little sound booth.
You might want to check with the regional hospital up there. I know when we do the health fair, they do hearing tests, and they might have a room, an area that you could at least have that in there that would be multi-purpose that you could use. So they have a senior group that works up out of there. They do a lot of education. Doctors come over lunch and talk to people and those type of things. And that might be a place, it's on the north end of Woodland Park, and it certainly would be on the main street for people coming from Park and other areas. So you might check with the regional hospital.
Oh, we will do that, yes. That's been one of our things that we do toss around often because we haven't been going up there like we used to. So.
I have a question about loss of hearing aids and technology. One of the biggest problems for seniors who are in and out of care facilities, never mind losing your hearing aid wherever. Is there anything such as tracking technology to track pets?
Oh, no, there isn't. But, that is a problem in all the years I've been doing this. Hospitals and rehab centers and care facilities, that's where hearing aids get lost.
I didn't think there was, but I would like to raise a really large banner for tracking for hearing aids. They can't be replaced either often, and neither can pets.
Yes. What was it you were telling me about?
You see the analogy?
The person that's, you were telling me yesterday about some sort of form that.
Somebody called me yesterday that stated she had just read that if you declare before you go into those facilities, I have hearing aids, write your serial numbers on there with a declared value of X, that they are then liable for them if they lose them while you are under their care.
That's good.
That's a really important question, because those hearing aids cost a lot of money, whether, no matter what. So I think it's the case is self-evident. We just need to build a formal voice to get them. I know the technology is available. Nobody's just ever thought about a hearing aid as a pet.
Right. Yeah, right, yeah. That's right. Well, again, thank you. Thank you so much. It's always a pleasure to come here.
We appreciate your services. Thank you so much. What's the we run late, but with enormous good information. Are there any additional information from our RAC members of community information we don't provide? No?
Just a reminder that the holiday dinner dance is coming up in a couple of weekends, and it's not too late to encourage anyone you know who wants to participate to sign up, and they can contact the Senior Resource Council for that. But more importantly, if you want to volunteer, it's a pretty fun event, and you get to be a waitress or a waiter, wear black pants and a red top, and pamper everybody who comes to the tables, bring them cocktails, bring them their dinner, and listen to big band music. It's a fabulous event at the City Auditorium. So,
What date?
November 12th.
thank you. Saturday, November 12th.
I'm sorry, I forgot to introduce also Chris.
Hi, Chris Breyer.
Say something too.
No.
Oh, you
I'm
want-
just here to answer questions
Oh,
about any
I'm
financial
sorry,
or
okay.
questions about the community. And if you still do, please find me.
So that's it. Just November 12th, holiday dinner dance. One of the biggest programs the Senior Resource Council puts out every year.
That's what's windy.
Gary. Oh, holiday information is where we're going next. Our next RAC meeting, notice, we do not have a RAC meeting in November, but our holiday RAC meeting will be December the 8th at
10.
10 to 1 in this room. In this room.
And it will be a combination meeting and potluck lunch, so information about that will be sent out as we get closer to the date.
And there is none in November.
Nothing in November because we meet the last Thursday, and I don't think anyone's going to plan on showing up
Because
here.
you backed it up last year.
Unless, of course, someone wants to bring the turkey and we'll have a dinner. But that's, I'm not being serious. So, put on your calendar, December the 8th.
Won't be here.
Okay, you won't?
Virginia.
Oh, well then enjoy.
I will.
If there's nothing else, this meeting is adjourned. Thank you very much, and thank you all in the audience for your forbearance of hanging in there with us. I hope it was valuable to you.
I guess we'll be seeing each other in the TRS, right?
And what happened to Joe, the other one?
He is at the C4A meeting.
And it might be able to do some stuff via email to start, because it's not that big of a number.
See how many they're going to get into.
Yeah, that's true.
Thank you.
Front of building 5, the back of the building is just. Yes, that's the front of the building.